pre-test, when you submit it, you get the right answers and explanations as well. You can save your these responses and go through that. This will also help you clarifying some of the doubts, and also it will help us in bringing uniformity in clinical practice.
Good afternoon, ma'am.
Good afternoon.
Ma'am, uh, advisor sir will not be able to join today
Acha, acha.
due to some medical emergency. And one of our speaker has also joined, Dr. Pradeepa madam.
हाँ हाँ
Dr. Manoj will join in half an hour.
ठीक है.
So we can continue with our session today.
Okay.
So may I start the session, ma'am?
Let them do the pre-test.
Okay.
Okay, you start it. Then
Uh,
give them some time to do the pre-test.
okay, ma'am. In 5 minutes, we'll start.
Yeah, let them give them some time to do the questionnaire also.
Okay.
Good afternoon, everyone. Welcome to the 40th session of the implementation of standard treatment guidelines in the series conducted by NHSRC and DSP RUD. This is the 40th session and fourth session of this fourth series of this. We've been doing this program for last consecutive 4 years now. And we have had a very good response from the participants. This program has been appreciated by most of you, and on popular demand we are continuing these sessions. Our aim is mainly to implement, increase awareness about the guidelines and implement these at the health facility level during your clinical practice. Although most of you must be already aware of the guidelines for management, but many a times we have seen that there is a difference in the knowledge and what is being practiced. Sometimes it is because of the outdated practices. When these new guidelines uh, are not implemented at the ground level, it could be because of that. Or maybe there are some systematic problems, system related problems, such as availability of the drug, the availability of manpower, the patient load, at the primary care level may be responsible for some of these. But it is been seen, it has been proven by repeatedly by many people studied, and they see if these are formally introduced to the clinicians, the uptake of these guidelines is better. And one of the greatest advantage that we have uh, from these guidelines is that they reduce inappropriate variation in clinical practice. Although we do recognize that the practices may vary depending on the patient characteristics, comorbidities, situation, level of health care facility, type of infrastructure available, but yet it has been seen that the basic treatment remains the same. It is the referral criteria which may differ depending on the availability of the infrastructure. So largely, if there are inappropriate variation which are not explained by the individual patient's characteristic, those are not desirable, and then they may threaten patient safety and also threaten uh, uh, outcomes, clinical outcomes in our day-to-day practice. And often the primary care facility are the first contact for these patients, especially with the psychiatric disorders or the substance use problems may go unnoticed if you are not looking for these. And it is the, because they are the right frontline person who would be dealing with this, it is very important to recognize these symptoms. Many times it has been seen that patients with psychiatric problems, they get masked by some somatic symptoms. So that is why we thought that these two topics are very, very important for the discussion today. We have two eminent psychiatrists with us, Dr. Pratibha Gelawat and Dr. Manoj Kumar. Both are my colleagues. We all of us today, it's a coincidence, Pratibha, that all of us are from IBHAS today. But yes, usually we get speakers from various different places. But since the topic was such and we were the most rightly suited resource person for this. So anyway, good to it will be good to listen to our own colleagues here. I think with this, you must have already opened the pre-test link and must have started attempting doing this test. Let me see if everything is going right at the back end. Yes, I've got few responses as well. Please finish this pre-test. And most of you, I think those of you who are returning participants in this series, you know the format that we start with the pre-test, then we have these expert sessions followed by question and answers, then post-test and a feedback. Now, Ranjit has been from NHSRC has been trying very hard to get the credit hours from the Delhi Medical Council. And for this session, I hope, Ranjit, you have already got the credit hours.
Ma'am, we have applied for the credit hours, but the approval is still pending.
Okay.
So, but in the registration column, we have already taken the registrations of medical officers. So,
Okay.
if approval gets, we will issue the credit points to them.
Okay, then okay. Since he's really working very hard to get these credit hours for you, please bear with us because until then we hear from the Delhi Medical Council, we will not be able to issue these certificates. I've been getting emails for the last session on antimicrobial stewardship. Have they been issued, Ranjit?
No, ma'am. For the last sessions, the certificates are still in process. We'll
Okay.
release by next week.
Okay, so we are waiting for the reply from the Delhi Medical Council, and we would like that these credit hours are mentioned in your certificate. So that is why we are not issuing right now. Please bear with us, but you will definitely get if you fulfill the requirement of undertaking both pre and post tests, attending through the session. It will be helpful. I think Pratibha, we will start at 3:15. It is 3:12 right now. Let's give them 5 more minutes to do the pre-test. Then we will begin with it. Okay.
Okay, ma'am. Okay. Shall I start sharing my screen till then?
Yeah, you can till that time. You can see if your presentation is uploaded.
Abhi stop. You can share, ma'am. I have your PPT. I can share from my end.
Let her try first. It would be better if she is able to do it on her own. If you have any difficulty, you can tell us, Pratibha.
I am having difficulty. I have to open it in window.
You can do it in screen. You have your presentation open.
Okay, on the screen, I will open the presentation and then share entire screen.
Yeah.
Okay.
Yeah. Are you able to share it now?
आपने डाउनलोड किया?
अपना पावर पॉइंट खोल के रख लो एंड देन यू कैन शेयरिंग में पूछेगा स्क्रीन शेयर करना चाहते हो या विंडो, तो विंडो करके देन यू सिलेक्ट योर पावर पॉइंट.
Now it's visible.
No.
Let's wait. Sometimes there is a lag. Are you able to see on your screen, Pratibha?
I am able to see.
Okay. But यहाँ नहीं आया प्रतिभा.
Okay, ma'am. Then I am not able to do. I have shared entire screen and I have opened it.
Okay, fine. I'll share from my end.
Okay.
Just let me introduce you with our all the participants. मेरा वाला slide पहले. Good afternoon, all. On behalf of Quality and Patient Safety Division, National Health System Resource Center, New Delhi, I extend a warm welcome to Dr. Sangeeta Madam, the President of Delhi Society for Promotion of Rational Use of Drugs, and to all participants and to all my two eminent speakers, Dr. Pratibha Madam and Dr. Manoj Kumar. For the today's sessions, Dr. Pratibha will take the first session, and she is an accomplished psychiatrist and academician, currently serving as an associate professor in Department of Psychiatry at Institute of Human Behavior and Allied Science, New Delhi. She has completed MBBS and then MD in Psychiatry from Pandit B.D. Sharma University of Health Science, Rohtak. She is having a good, extensive experience across premier institutions like AIMS Jodhpur and state mental health institution. She has led and contributed to multiple research projects also, particularly in the areas of suicide prevention, telepsychiatry, substance uses, and child and adolescent mental health. She has an impressive academic portfolios with numerous PubMed index publications and book chapters, along with active involvement in teaching, workshops, and capacity building programs. She is also a life fellow of Indian Psychiatric Society and Delhi Psychiatric Society, reflecting her strong engagement with this professional community. I request Madam to take over the session and enlighten our participants with the topic.
So, good afternoon, ma'am, and good afternoon, everyone. I think the slides are not there.
Yes, ma'am. Now sharing it. Sharing.
Okay, okay, okay.
It's now visible to all.
I would request if you keep it in the not in the slide share mode and in that mode only, which the side slides are visible. I would request that because
Okay.
few of the slides the content is like it is not fitting into one slide, so that is why I would like to. Okay, thank you
Okay.
so much.
Pratibha, अच्छा, but then okay, इसमें some of the student participants may not be able to see. Some may be joining us from the telephone. तो screen already छोटी होती
Okay,
है.
okay, then you can do. I'll हाँ,
Right, okay.
हाँ, आप स्लाइड शेयर कर दीजिए.
Full slide. So.
Okay, thank you, ma'am, for the opportunity, and
Yeah.
thank you NHRC for giving me this topic. This is indeed a very important topic. I have told about to discuss the screening, the diagnosis, and the support, the first line support, and the referral triggers, which are beneficial for the primary healthcare workers. I do not know whether this session is going to be interactive or not, or whether I have to speak like this.
No,
So,
try to be as interactive as possible. The participants can write their questions and answers in the chat box. Maybe you'll have to keep looking at it. It is your style, whatever you find it okay,
okay.
whether during the session or at the end. So it is entirely up to you. How do you go about it?
So next slide. Before talking about the screening part, we must know what is mental health and what are actually common mental health disorders, which usually come to us. The previous slide, please. Which usually comes to us in the because first of all, the gatekeeper, the gateway to any of the patients in our country, it is nowadays it is not top down model, it is down to up model. So first contact is with the primary care, with the ANMs, with the medical officers, or sometimes in the villages to the ASHA workers also. So we have to actually know the importance of mental health and the what is mental health. And if we know what is mental health, then we have to look for the common mental health disorders. So mental health, it is an integral part of our health, as important as our physical health. Okay. So mental health includes we are the state of well-being in which we are doing our functional work, we are capable, we are providing a productive life to the society. Okay. So the complete definition includes all the things. So mental health is very important for the functional work of the person. Okay. So therefore we should be very vigilant to actually screen about the mental health disorders. So, what are the common mental health disorders? The common mental health disorders, substance use disorders, will be covered by our colleague only in the other talk. I will be covering the common mental health disorders, which include depression, anxiety disorders, and somatic disorders, and they are frequently encountered in the primary care settings. So if someone on the speaker can share their experiences about the number of patients visited their OPDs or the inpatient clinic, and you are accidentally finding that they are giving some history which is mimicking the symptoms of anxiety or depression or anything else, so they can speak up, or I would like to continue in this way. So, if anyone wants to share their experiences about the mental illness, the encounter of mental illness there in their setting.
The participant cannot respond. They have to write in
They have
the
to
chat.
keep writing. Okay, okay. So I have to open the chat box also. Okay. Anyways, so I would like to continue with it. So if we talk about the common mental disorders, the common mental disorders include three things, mainly three or four things. One is depression, other one is anxiety disorders, and the third one is somatoform disorder. Fourth one is the substance use disorder. So the initial three, the depression, anxiety, and somatoform. Somatoform usually वी एनकाउंटर इन ओपीडी. आपके पास ओपीडी में बहुत सारे मरीज आते हैं, बहुत सारे आते हैं जो ये बोलते हैं कि वी आर हैविंग हेडेक, persistent headache हो रहा है, persistent backache हो रहा है, persistently there are some difficulties which they are finding in doing their day to day things, day to day routines. So in those cases, when the unexplained symptoms are there, unexplained somatic symptoms are there, when in the investigations, although also in the clinical findings, also in the physical clinical findings, also examination also, you rule out that there is no physical cause to it. So then the unexplained symptoms, medically unexplained symptoms, I would say, then we should be labeling them to as somatoform disorders, in which the medical cause is not we are not able to find out any medical cause, and there are unexplained symptoms, somatic. So these are very common. More commoner we will see in our OPDs than depression and anxiety disorders, क्योंकि depression and anxiety disorders में patient आके ये बताता है generally कि उसको उदासी या जो भी उसके कोर इमोशनल डिस्टर्बेंसेस हो रही हैं, वो थोड़ा सा वो अपने आप से भी बताता है. बट इन सोमाटोफॉर्म डिसऑर्डर्स इट बिकम्स वेरी difficult also to. So these three are the common disorders. We should be very vigilant enough, very much known enough, aware enough, so that we can ask in the and the other one, substance use disorders, will be taken up in the next lecture. Then what are the clinical features and diagnostic criteria? The clinical features for common mental disorders like persistent sadness, loss of interest in routine activities. It is not routine activities, it may be previously pleasurable activities कि पहले उसको खेलना अच्छा लगता था या पहले उसको कोई स्पेसिफिक चीज करनी अच्छी लगती थी, पेंटिंग अच्छी लगती थी, अभी वो वाली एक्टिविटीज जो वो पहले एंजॉय करते थे, नाउ they are losing interest in those activities also. So loss of interest in previously pleasurable activities becomes very important. Then excessive worry and unexplained physical complaints. So these are the clinical features which commonly are seen. Next slide please. Next slide. So the most common we talk about is depression. I am studying a case study in which a 45-year-old patient presents with pervasive sadness, anhedonia. Anhedonia is loss of interest in previously pleasurable activities and fatigue for over 6 months, significantly impacting daily functioning. These symptoms are consistent with depressive episode. Okay, so what are the three symptoms in which three core symptoms we are seeing in this? There is pervasive sadness of mood, which is usually आप पिछले कुछ दिनों से में पिछले कुछ हफ्तों से या पिछले 2 हफ्तों से, अगर टू बी वेरी मोर प्रिसाइज, अगर वो पिछले 15 दिन से या 2 हफ्तों से हो रहा है और वो भी परवेजिव है, नॉट ओकेजनल सैडनेस, देन इट इज द कोर सिम्टम ऑफ डिप्रेशन. एनहीडोनिया भी परवेजिव है पिछले 2 हफ्तों से या उससे भी ज्यादा हफ्तों से, if it is loss of interest in previously pleasurable activities, and fatigue is कि there is low energy, not able to do, मतलब functional impair, significantly impacting the daily functioning. So all these include the core symptoms of depression, so that is why we are able to identify. But definitely we do not see the patients with all the three core symptoms, और हमें कई बार पोक करना पड़ता है पेशेंट्स को कि आप बताइए कि क्या प्रॉब्लम है. देन आफ्टर पोकिंग एंड आफ्टर केयरफुल एग्जामिनेशन एंड केयरफुल हिस्ट्री टेकिंग, then the patient comes up with these symptoms. So these are the book symptoms, but we have to learn the skills how to explore those symptoms or how to make the patient. Then definition includes, it is a mood disorder. These three symptoms I have already said, and it has many other types, but we have to learn about depressive disorder. It has many other types like persistent depressive disorder, जिसके अंदर आपको पूछना है कि कितने सालों से रह रहा है. अगर वो 2 साल से ज्यादा रह रहा है तो दैट मीन्स डिस्थाइमिया है, या फिर वो पहले भी बहुत बार हुआ है तो वो रिकरेंट डिप्रेसिव डिसऑर्डर है. इस तरह के एपिसोड्स पहले भी बहुत बार हुए हैं और फिर दवाई लेने पे या बगैर दवाई लेने पे या कोई और इंटरवेंशन लेने पे ठीक हुए हैं. सो दैट मीन्स दे आर रिकरेंट डिप्रेसिव डिसऑर्डर. एंड कैन बी सीजनल अफेक्टिव डिसऑर्डर, कि हर बार जब भी सर्दी आती है या मौसम चेंज होता है या जब भी इस तरह की होते हैं तभी ये वाले लक्षण आते हैं. सो types of depression we can find out. Core and additional symptoms may include कि sleep, appetite, sleep होगा reduce, appetite reduce हो जाएगी, may be increased, may be decreased. कुछ लोगों में atypical symptoms आएंगे कि sleep increased हो जाएगी, appetite भी increased हो जाएगी, कुछ लोगों में दूसरे तरह के की decrease भी हो सकती है. और there is variation routine में, there is a definite change in the behavior and the premorbid norm of the patient. So only then we are able to make out that. Many times patients may come up with the symptoms of having death wishes और suicidal ideas. ऐसा करता है मन की भी हमें जीने का मन ही नहीं करता, या फिर बहुत सारे एक्टिवली विचार आते हैं कि हम अपने आप को नुकसान पहुंचाएंगे. So these are all things which we need to ask and also explore in the patients coming to us. Next slide, please. So diagnostic criteria, once again, it is the same. I will not repeat it. 2 consecutive weeks with one symptom being depressed mood or pervasive loss of interest in previously pleasurable activities, which is anhedonia. And these criteria are essential for accurate diagnosis in primary care settings. और अगर हमें ये भी नहीं पता लग रहा है, ये यूजुअली हम 1-2 सिम्टम से या फिर हमें लुक से या फिर कोई ठीक नहीं हो रहा है पेशेंट, बार-बार आके कंप्लेन कर रहा है कि आई एम नॉट फीलिंग वेल, नॉट फीलिंग वेल, सो वी हैव टू प्रोब फॉर these questions in which we will be asking for the depression. Very commonly used scale is PHQ-9. PHQ-9 is very commonly used scale to diagnose depression in the primary care settings. Okay, when the score is 4 or more than 4, then it is depression. Then symptoms and duration of impairment is usually 2 weeks or more than 2 weeks. So next slide please. Then coming to after depression, we need to understand the anxiety disorder. For anxiety disorder, this is Mrs. Sara, a 20-year-old college student who experiences intense worry about academic performance and social situations. She often feels overwhelmed, have difficulty in sleeping, and avoids group activities due to fear of judgment. Her symptoms have worsened over the past semester. So here we can see that first thing, she is intensely worried. The second is her academic performance is also impacted due to the intense worries. And she is also having the anxiety going to the social situations. So these worries, they increase and she often feels overwhelmed, difficulty in sleeping and avoids group activity. So avoidance behavior is also there due to fear of judgment. So these are worsening. So anxiety, to define anxiety in this patient, there is a clear cut. I have chosen the cases in which there are clear cut. So just to make out that these are the things which are found in the anxiety disorder, and these are picture book uh, symptoms which I am discussing. But as a physician, as a primary care health worker, or the medical officers, you have to rule out, you have to explore the things, and you should learn the skills how to ask for them. So that I will be covering shortly. Then definition and types of anxiety. Anxiety is a natural phenomena, natural human emotion होता है. अब हमें कोई भी ऐसे बोलेगा कि मुझे एंजाइटी हो रही है, तो एंजाइटी एक नेचुरल चीज़ है किसी के लिए भी. सो जब वो एक्सेसिव हो जाती है, बट व्हेन इट बिकम्स एक्सेसिव, persistent and interferes with daily life, it may indicate an anxiety disorder. So this is very important. कोई भी आपको आके कोई स्ट्रेस में है या कुछ छोटी मोटी चीज हो गई या फिर अभी एग्जाम भी आने वाले हैं, ठीक है, तो एक यू स्ट्रेस होता है और एक एंजाइटी है, वो एक नॉर्मल ह्यूमन फिनोमेना है. इट इज बाउंड टू हैपन, बट this is important. We have to delineate when it becomes excessive, persistent and interferes with daily life, then we label it anxiety disorder. Do not label anyone as the patient of anxiety disorder. So common types include generalized anxiety disorder, social anxiety disorder, panic disorder, and social phobias. This normal anxiety is typically temporary, proportional to the situation, and doesn't significantly impair functioning. However, disordered anxiety conversely is disproportionate, persistent, often remain for months, and causes significant distress or impairment across multiple life domains. So this is very important to know. तो इसमें हम अगर वन बाय वन जाएंगे, जनरलाइज्ड एंजाइटी डिसऑर्डर है, नाम से ही आपको पता लग रहा है कि उसको हर वक्त, हर छोटी चीज के लिए हर वक्त एंजाइटी रहेगा. ठीक है, कोई भी ट्रिवियल मैटर हो गया, कुछ भी हो गया, डे टू डे लिविंग एक्टिविटीज हो गई, डे टू की बाहर जाते हैं तो भी ये लगता है ऐसे हो जाएगा, अंदर घर में भी ऐसे लगता है कि बच्चों के साथ ऐसे हो जाएगा, या कुछ भी डे टू डे एक्टिविटीज में नॉर्मली जो हम रूटीन फॉलो कर रहे हैं उसी में ही एंजाइटी रह रही है. एंड इफ इट इज परसिस्टिंग फॉर ओवर 6 months, देन वी लेबल इट एज 3 to 6 months, then we label it as generalized anxiety disorder. In social anxiety disorder, in the social situations, when the patient says कि मुझे बाहर social situations में जाने में डर लगता है, I usually avoid going to the weddings, I usually avoid functions, I usually avoid the seminars or anything else, जहाँ पे भी socially उसको बोलना है, in those cases it is social anxiety disorder. Panic disorder, we already know panic attack होता है तो उनकी feeling होती है. There are sympathetic arousal, ठीक है, nervous system. We have and other things and तो ऐसे लगेगा कि नहीं मुझे अभी कुछ हो. When they reach to the emergency, is done or everything is nothing so medical people, and we see that is a more than one panic attacks and label them as a panic. Lastly, specific phobias can.
Pratibha, your internet is dropping in between. Can you move to a place where there is a good connection?
Oh,
Ma'am, you can temporarily stop your video camera, so the network will be good in case that.
Pratibha, you can move, continue. Hello. Yeah.
now it's fine.
I think it should be okay.
Ma'am, just put off your camera, so the network will be good.
Okay.
Continue speaking, but put off. Okay. Thank you.
Now it's fine.
Yes.
I hope I am audible. Okay. So we were on the last specific phobias. Specific phobias, they include, they मेनली कि किसी को छिपकली से डर लगता है या किसी को पानी से डर लगता है या किसी को सो स्पेसिफिक थिंग्स से जो भी डर लगता है और उसको यूजुअली अवॉइड करते हैं लोग. सो दैट इंक्लूड स्पेसिफिक फोबियाज. So these are the different types of anxiety disorders which we face and which usually comes in the primary care settings. Next slide, please. So I have already told you generalized anxiety disorder. ये generalized condition में excessive worries about everyday things. It is characterized by persistent excessive worries about everyday things, day-to-day things. Panic disorder and social anxiety disorder. Panic disorder includes sudden, severe attacks of fear and physical symptoms affecting the persons. And social anxiety disorder, a fear of social situations impacting many persons. Where we see the stressor is quite strong or quite uh, strong enough, we can label them as they faced a significant trauma. Significant trauma includes death of some near one, or any calamities, natural calamities, or any rape victim or any type of victim. Aggression के लिए victim हो सकता है, domestic violence के victim हो सकते हैं. So all those, and after those incidents, significant incidents occurred in their lives, they face the traumatic events later on. They just go through these trauma and revisit in the memories, and they have the night awakenings due to this fear. Next, please. I think I have covered this. Autonomic hyperactivity and associated symptoms. Autonomic hyperactivity में क्या क्या होगा? Restlessness आएगा, feeling keyed up or edge, being easily fatigued, difficulty in concentrating, mind going blank, irritability, muscle tension, sleep disturbance, and these somatic symptoms contribute to substantial discomfort and impairments for the patient. सो वी नो दैट कि इसके अंदर हमारे को पेशेंट्स को ऐसा लगेगा कि हमें घबराहट नहीं है, हमें ज़्यादा फिजिकल सिम्टम्स है. सो दैट इज वाई दे विल कम टू दी प्राइमरी केयर सेटिंग्स और द फिजिशियंस फर्स्ट and do not visit the psychiatrist. So they have to be treated by the physicians, or if it is severe enough, then they have to be referred to the specialized psychiatric centers. We can do the screening with generalized anxiety disorder, anxiety disorder scale 7, and this is a very important tool which is used in the primary care settings. Next, please. Next, please. Okay. Other anxiety disorders, panic attacks, anticipatory anxiety is there, addressing fear of social scrutiny and avoidance behaviors, recognizing traumatic memories, and hyperarousal. So this is very important because nowadays the situation after COVID, it has become so severe, so unpredictable. Severe nahi, unpredictable, that anytime war will happen, anytime there are chances that, because natural calamities are becoming many, many, and we on the digital media the persons are seeing. So वर्चुअल पीटीएसडी भी बहुत ज़्यादा होने लगा है कि लोगों को अगर डिजिटल मीडिया में न्यूज़ देख के और वॉर का न्यूज़ देख के या और भी किसी और को ट्रॉमा पहुंचा है वो वाला न्यूज़ देख के, एंड दे हैव दी हाइपर अराउजल सिम्टम्स, सो दे कम टू the clinics with the overwhelming anxiety symptoms, and they feel stressed out. So these also needs to be taken care of. Next, please. Next slide, please. Then coming to bodily distress disorder, somatization disorder. For this, a 45-year-old patient presents with persistent fatigue and diffuse body aches over 6 months. Despite extensive medical workups showing no clear organic cause, this highlights the challenge in diagnosing and managing such cases. So these are definitely the cases I would vouch for that in the primary care settings. I think it is almost 40% of the cases they come with chronic physical complaints, and it can be more than 40%. If I would require some corrections from the colleagues who are listening to this. So, definition and clinical features: bodily distress disorder. Formerly, it was known as somatization disorder. Usually, अभी भी WHO somatization disorder ही use कर रही है. Involves bothersome physical symptoms causing significant distress or functional impairment for which the medical explanations are insufficient. ओके हर तरह के टेस्ट कराते हैं, एक फिजिशियन से दूसरे फिजिशियन के पास चले जाएंगे, दूसरे से तीसरे के पास चले जाएंगे, देन दे गो फॉर हायर एंड इन्वेस्टिगेशंस आल्सो, बट सब कुछ ऑलमोस्ट नॉर्मल आएगा, एंड देन रीअश्योरेंस के बाद में भी उन्हें ये लगता रहेगा कि दे आर एक्चुअली हैविंग द physical symptoms, any physical symptoms. So core features include multiple varying physical symptoms. This needs to be very important. This is usually the challenging patient in which these things come, because they are utilizing the resources, they are also utilizing the doing the doctor shopping also, and definitely causing the wastage of resources. So ideally, dealing with these patients important, diagnosing and then further managing these patients also becomes important. So diagnostic criteria, it requires persistent distressing somatic symptoms and excessive thoughts of feelings and behaviors related to them. PHQ-9 earlier हमने बात करी थी, that was used for diagnosing depression usually. PHQ-15 is useful screening tool showing good sensitivity and specificity for identifying somatic symptom burden. तो आप वो भी easily primary care setting में लगा सकते हैं. Next slide please. Next please. Then coming to dissociative neurological symptom, it often presents with wide array of neurological symptoms that can mimic organic disease. Early recognition is crucial to avoid extensive and unnecessary investigations. Epileptic, आपको true seizures or pseudo seizures का पता है? This is the new term which has been included in ICD-11 and DSM-5, the dissociative neurological symptom disorder. and very commonly present in the neurology clinics as well as the medicine clinics, that pseudo seizure like picture or dissociative neurological symptom disorder coming to us, and the gold standard is to do video EEG in these patients. Okay, it is frequently DND frequently manifests as a non-epileptic seizures, which are typically characterized by preserved consciousness and during episodes, lack of post-ictal confusion, often asynchronous limb movements. So in these cases, if we need a good delineation between the true seizures, we need to do the video EEG monitoring, which is considered as the gold standard for this. So for this, you may not be able to do as a primary in the primary care settings, but definitely if you are suspecting it to be a pseudo seizure and not able to explain to the patient, then definitely refer to the higher center to in order to get the uh, further investigation and delineate with the dissociation. Next slide. So, jerking movements, emotional trauma, we usually see, I think primary care settings में तो ये बहुत ज़्यादा होता है कि घर में किसी को फ्यूनरल देख लिया, या किसी का कुछ हो गया, या किसी और का कुछ हो रहा था, कोई लेके जा रहा था, तो उसको देख के भी डेड बॉडी लेके जा रहा था, तो यूजुअली फीमेल्स कम टू दी ओपीडी with this कि भी वो unconscious हो गए. So 45-year-old patient presented with sudden uncontrollable jerking movements, initially misdiagnosed as epilepsy. Though detailed psychiatric assessment, it was discovered that these movements were triggered by specific reminders of severe childhood trauma. This highlights the body's unconscious expression of unresolved emotional conflicts, a classical presentation of dissociative disorders. So we need to also understand about the dissociative disorders. They are very very commonly presented in the emergencies and treated in a way कि इसको तो कुछ नहीं हुआ. So that is the wrong thing we want to. अगर हम इस लेक्चर से ये समझा पाए, नहीं बोलना है कि इसको कुछ नहीं हुआ. जो भी इमोशनल ट्रॉमा है उसके लिए बात करो, उसको समझा पाओ तो उसको समझाइए, उसके साथ जो भी हो रहा है उसको थोड़ा सा वैलिडेशन करिए, एंड देन आफ्टर प्रॉपर काउंसलिंग यू सेंड बैक द पेशेंट. जस्ट segregating the patient कि इसको कुछ नहीं हुआ, it also worsens that thing. So dissociative disorders, they usually come to the primary care settings and then subsequently to the higher centers also, क्योंकि उनको लगता है कि वहाँ पे तो हमारे को, although we need to address the actual trauma they have been facing. For that we need to give time, but I think not saying this कि इसको कुछ नहीं हुआ, also you will actually say कि भी हाँ कुछ ऐसी प्रॉब्लम है या साइकोलॉजिकल प्रॉब्लम है जिसकी वजह से ये हो रहा है, हमें धीरे धीरे हम वो जानने की कोशिश करेंगे. एंड यू कैन ऑल्सो रेफर दीज पेशेंट्स इफ नॉट एबल टू find out any underlying trauma or anything stressor, then you can refer the patients to the higher center. Next slide. So in the treatment and management, pharmacological treatment for depression and anxiety, usually SSRIs, selective serotonin reuptake inhibitors, and non-pharmacological treatment, CBT, and I think next slide I will say. Next slide please. So SSRIs, tricyclic antidepressants, and SNRIs, serotonin norepinephrine reuptake inhibitors. These are the three most commonly used drug classes which are used to treat the, and serotonin reuptake inhibitors जो होते हैं, they are the most common drugs which are used in the treatment of depression. But before that, the treatment for depression should not be started with the antidepressants at first. You have to assess that whether it is mild, moderate or severe. So mild सिवियर के अपने कैटेगरीज हैं. आप PHQ-9 लगाएंगे. PHQ-9 में स्कोरिंग जो है 4-5 या उससे ज़्यादा आ रहा है, देन यू गो अहेड विद दी कि इसको डिप्रेशन है. फिर आप जो ICD-10 में है कि भी बहुत ज़्यादा लक्षण नहीं है, आप उसको माइल्ड मॉडरेट सीवियर कैटेगरी में अगर कर रहे हैं, अगर माइल्ड से मॉडरेट है तो आप उसमें काउंसलिंग, साइको एजुकेशन, लाइफस्टाइल मॉडिफिकेशन, सम रिलैक्सेशन स्ट्रेटजीज ये सब सिखाएंगे. अगर वो भी फिर भी वर्क नहीं कर रहा है, देन यू हैव as a medical officer you have the leverage to use. You start with the antidepressant also, but with a very low dose. Okay, so this is very important, but with a very low dose. Serotonin reuptake inhibitors में हमारे escitalopram, sertraline, fluoxetine, they are the commonly used drugs uh, uh, which are used to treat depression or anxiety. So we can start with very low dose. Next. Then the same is with bodily distress disorder. We can start with norepinephrine TCAs like amitriptyline, which is usually prescribed क्योंकि किसी को सर दर्द हो रहा है या body aches हो रहे हैं, or the fatigue part, or these things. So amitriptyline is considered to be the effective drug, but the side effects are known. So 10 to 25 milligram is acceptable, but if we go up to higher doses, then the side effects are very dangerous. So in the primary care setting, it is very important to be with the lower possible dose, and if the lower possible dose पे patient ठीक नहीं हो रहा है, then better to refer to the higher center. So we start with the antidepressant TCAs or anything with the lowest possible dose. Next. देन मैनेजमेंट एंड रेफरल ऑफ डिसोसिएटिव डिसऑर्डर, ये भी मैंने बात कर लिया है कि मिथ्स एंड स्टिग्मा आपको एड्रेस करना है, ज़रूरी है, क्योंकि डिसोसिएटिव डिसऑर्डर बहुत ज़्यादा प्राइमरी केयर सेटिंग में आता है. दे आर फ्रीक्वेंटली मिसअंडरस्टूड लीडिंग टू सिग्निफिकेंट स्टिग्मा फॉर द पेशेंट. ये स्टिग्मा जो होता है ना कि इसको कुछ नहीं हुआ, ये तो ड्रामा कर रहा है या ड्रामा कर रही है. सो दिस इज लेबलिंग ऑफ द पेशेंट, एंड देन दे फील उनका जो सेल्फ एस्टीम या उनका जो कोपिंग मैकेनिज्म है वो ऑलरेडी लो है, एंड इट बिकम्स फर्दर मोर लोअर डाउन. सो इट्स क्रूशियल फॉर प्राइमरी to educate themselves and patients, correcting the misconceptions. Dissociative open communication and non-judgmental stance, it is very important. You should be open to the communication, and non-judgmental stance can empower patients and reduce barriers for seeking effective treatment. उनको बताना भी है कि कुछ स्ट्रेस है तो आप साइकियाट्रिस्ट के पास या किसी मेंटल हेल्थ प्रोफेशन के पास जा सकते हो, और अगर वो आपको बता देंगे तो ये और भी अच्छी चीज़ है, बिकॉज उनका जो कॉन्फ्लिक्ट है या उनका स्ट्रेसर है वो बताने से ही आधी से ज़्यादा प्रॉब्लम जो है वो सॉल्व हो जाती है. सो वी हैव टू एड्रेस द मिथ्स एंड स्टिग्मा. Psychotherapy remains the mainstay treatment. Next. Then it is very important, ये last topic है ये हमारा, कि assessment and management of self harm and suicides. So एक पेशेंट अगर डिप्रेशन का है, वो आपको नहीं भी बता रहा है कि मेरे को सेल्फ हार्म आइडियाज हो रहे हैं या नहीं हो रहे हैं, एज अ मेडिकल प्रोफेशनल एंड मोर इम्पॉर्टेंटली इफ़ यू आर मेंटल हेल्थ प्रोफेशनल, तो बहुत ही ज़्यादा ज़रूरी है कि वी हैव टू आस्क द पेशेंट whether having any ideas of self harm or not. It is not that कि अगर हम उससे पूछ लेंगे तो हम उसके अंदर आइडिया इम्प्लांट कर देंगे. नो, वी हैव टू आस्क कि आपको, क्योंकि ये एक बहुत बड़ा मिथ है कि हम पूछेंगे तो हम पेशेंट को एक आइडिया इम्प्लांट कर देंगे, उसको फिर ये सब आने लग जाएगा. नो, इफ़ वी हैव टू प्रिवेंट सुसाइड प्रिवेंशन में ये थंब रूल है कि वी हैव टू इंक्वायर अबाउट द, अगर हमें कोई डिप्रेशन का पेशेंट नज़र आ रहा है या फिर कोई ऐसा पेशेंट जो क्रॉनिकली इल है या सिवियर फॉर्म ऑफ डिप्रेशन में जा रहा है, या उसको सिवियर है किसी भी चीज़ का, एंजाइटी का, या एनी ट्रॉमा विच हैज़ बीन सिग्निफिकेंट इनफ, सो वी हैव टू आस्क फ्रॉम द पेशेंट्स दैट इफ दे आर हैविंग एनी आइडियाज और थॉट्स ऑफ सेल्फ हार्म और नॉट. So this question is very important, and accordingly we will do the suicide risk assessment. क्योंकि बहुत सारे मरीज आपके पास ऐसे भी आते होंगे जो कोई अटेम्प्ट करके आते होंगे, ठीक है। तो अटेम्प्ट के बाद में आप उसको बोलते हैं कि आप मेडिको लीगल एमएलसी कराओ अपना और ये कराओ, उससे भी ज़्यादा ज़रूरी है यू डील विद द पेशेंट एंड डू अ रिस्क असेसमेंट कि उसने पास्ट में कोई अटेम्प्ट तो नहीं किया, उसने उस अटेम्प्ट के लिए कोई प्लानिंग तो नहीं करी थी, या वो एक इम्पल्सिव अटेम्प्ट था, या उसने प्लान करके किया, उसने प्लान करके ऐसा किया कि किसी को पता ना लगे। तो ये सारी चीज़ें पूछना ज़रूरी है जिससे कि हमें रिस्क असेसमेंट होगा, और अगर किसी का हाई रिस्क आ रहा है तो उसके अंदर हमें मरीज़ को डेफिनेटली हायर सेंटर में रेफर करना। नेक्स्ट स्लाइड प्लीज़। Then now I have common mental health disorders. Psychosis के बारे में मैं अभी बात नहीं कर रही हूँ because I am just focusing on the common mental disorders in this slide. So what is the screening, identification and diagnosis? हमारे 3 गोल्डन क्वेश्चंस होने चाहिए इनिशियल स्क्रीनिंग के लिए। आपको कुछ नहीं पता, पेशेंट आपके पास आया है, तो अगर आप ये भी कर लेंगे कि हम ये 3 गोल्डन क्वेश्चंस पूछ लेंगे इनिशियल स्क्रीनिंग के लिए, सो दैट बिकम्स वेरी इंपॉर्टेंट. The questions are on the next slide, please. Have you been, या फिर आप अटेंडेंट से पूछ रहे हैं तो has the patient been feeling sad, worried or anxious recently? Has there been any disturbance in your sleep or appetite? Caregiver से पूछ रहे हैं तो patient's sleep or appetite. Has there been any recent change in your or patient's behavior? For example, founding talking to self, poor self care, withdrawn, or not talking to, or not doing the things, any irrelevant talking or not doing the things appropriately which he was doing earlier. So these are the 3 questions you need to ask in the regular assessment also to screen for the mental disorders. So these has been included in the WHO and also the Ayushman wala part जो नए modules बने हैं. तो these are the 3 golden questions we have to be using in the regular assessment when a patient comes to you in the primary care settings. Okay, next slide please. Then it is very important कि आपकी interviewing skills भी क्या होंगी. Adopt an engaged posture and eye contact. ऐसा नहीं है कि आप बस ये 3 क्वेश्चन पूछ रहे हैं, उसमें yes no आ गया तो बस ठीक है, हो गया. You have to be very empathetic with the patient. With the busy clinical settings, it is very very difficult अगर हम ये कहें कि भी हाँ आप हर patient के साथ में ये, but you have to actually 1 or 2 minutes का extension तो करना पड़ेगा so that you are able to pick up with the patients that हाँ इसको कुछ तो एक mental health concerns लग रहे हैं, कुछ तो issues लग रहे हैं, so that we are able to identify that and initiate the proper treatment, and wherever referral is required you. So in this way, adopt an engaged posture and eye contact. Begin with casual conversation and open-ended questions. Active listening and summarizing with the clarity. So these are the things I think. अगर हम 1-to-1 बात करते हैं तो you understand कि आपको listening skills तो होने ही चाहिए, and you have to ask the relevant questions also to the from the patients. Next slide. So examination for mental disorder diagnosis, observing appearance and facial expressions, which is key to the initial assessment. Observing patients' appearance and facial expressions can offer immediate non-verbal cues about their mental state, and this initial observation often sets the stage for further inquiry. A detailed assessment can reveal signs of distress, neglect and unusual behavior. So observation बहुत ज़रूरी है, appearance and facial expressions, which is key to initial assessment. Then assessing speech and physical manifestation.
I think our connection is lost. Ranjit, can you talk to her?
Yes, ma'am. I am trying to call her. रिकॉर्डिंग हो रहा है। फिर से स्टार्ट कर सकते हैं।
So interviewing, I was on the second part, assessing speech and physical manifestations. So speech का rate क्या है, speech का tone क्या है, speech कितना output हो रहा है, all these things are very, वो आप अगर normal conversation भी कर रहे हैं किसी disease के बारे में, then also you can pick up about the pace, about the coherence की irrelevance है, coherent है या नहीं है. So all those things we can pick. देन अगर आपको पहले दो चीजों में ऑब्जर्वेशन, अपीयरेंस एंड फेशियल एक्सप्रेशन एंड स्पीच वगैरह में आपको अगर कोई डाउट्स लगते हैं, ऐसा लगता है कि देयर इज समथिंग एबनॉर्मल, यू आर देन वी हैव टू डेफिनेटली इंटरव्यू द पेशेंट सेपरेटली एंड ensuring the confidentiality and trust. So अगर ऐसा भी लगता है कि ये सब है और पेशेंट आपको कहता है कि मुझे आपसे अलग से बात करनी है या मुझे कुछ ऐसा बताना है, देर आर सम पेशेंट्स ऑफ डिप्रेशन या फिर किसी को कुछ ट्रॉमा है, सो willingness to talk to the patient separately also should be there to pick up the psychiatric disorders very early. So next slide. Then first line support में आप understanding the medical illness as medical condition, emphasize that mental disorders are legitimate medical conditions like diabetes or heart disease with biological, psychological, and social factors contributing to their development. And this approach can help reduce the stigma and encourage adherence to the treatment plans. ये बहुत ज्यादा जरूरी है कि आपके लेवल पे ये एजुकेशन हो कि भी इट इज एज इम्पोर्टेंट एंड एज कॉमन एज द मेडिकल कंडीशन, एंड आप उसको लेबल नहीं करें कि ये साइकियाट्रिक डिसऑर्डर है. So that stigma should be reduced. Treatment assurance and medical guidance. Reassure patients and families about the effectiveness of various treatments, including medication, and provide clear, concise information about how medications work, potential side effects, and the importance of consistent use of optimal outcomes. आप जो भी ट्रीटमेंट स्टार्ट कर रहे हैं उसके बारे में एक्सप्लेन करें और हमेशा लो डोज में स्टार्ट करें, बिकॉज इन प्राइमरी केयर सेटिंग्स द यूज ऑफ साइकोट्रॉपिक्स इज यूजुअली लिमिटेड टू लोअर डोजेस, कि आप अपनी तरफ से इनिशिएट कर दो ट्रीटमेंट एंड देन अगर आपको लगता है लो डोजेस में अगर नहीं ठीक हो रहा है, देन बेटर टू रेफर द पेशेंट टू द स्पेशलाइज्ड ट्रीटमेंट सेंटर. Encouraging lifestyle modifications and follow-up, this should be done at the primary care setting only. कि भी जैसा आप डायबिटीज के पेशेंट में या हार्ट डिजीज के पेशेंट में या फिर कोई भी क्रॉनिक डिजीज कंडीशन में समझाते हैं कि आप लाइफस्टाइल मॉडिफिकेशन करिए और फॉलोअप को रखिए डाइट के थ्रू, एक्सरसाइज के थ्रू, स्ट्रेस मैनेजमेंट, रिलैक्सेशन एक्सरसाइजेस के थ्रू, डूइंग सम adding some extracurricular activity in your routine like yoga or meditation or anything. So these modifications should also be told at your level, and it serves as a first line support to these patients and families. Next slide. Then treatment and management of the mental health disorders. Addressing mental health in primary care सबसे important है. Primary care settings are crucial for early detection and intervention. Early detection सबसे ज्यादा important है. So I am still focusing on कि आपको detection पे बहुत ज्यादा ध्यान रखना है, क्योंकि उसी के बाद intervention offer कर पाएंगे. Intervention of mental disorders, offering accessible points of contact for many patients. Integrating mental health services into primary care can significantly improve outcomes and reduce the stigma for psychiatric conditions. Collaborative care models and navigating the treatment challenges. This is more of theoretical. So whatever anxiolytic, SSRI, या फार्माकोलॉजिकल ट्रीटमेंट आपको स्टार्ट करना है, उसका सेफ्टी प्रोफाइल और उसमें लोएस्ट पॉसिबल डोज में आप स्टार्ट करिए। नेक्स्ट स्लाइड। फार्माकोलॉजिकल ट्रीटमेंट प्रिंसिपल्स क्या है आपके, कि प्री ट्रीटमेंट असेसमेंट जरूर करना है, क्रूशियल फॉर पेशेंट सेफ्टी। उसमें आपको बिफोर इनिशिएटिंग एनी साइकोट्रोपिक मेडिकेशन थॉरो असेसमेंट इज पैरामाउंट एंड इट इंक्लूड्स मेडिकल हिस्ट्री लेना है, फिजिकल एग्जामिनेशन, रेलेवेंट लैब इन्वेस्टिगेशंस to rule out underlying medical conditions and these things are important. So lab parameters में LFT, KFT, lipid profile and your BMI and other parameters should be noted down before starting with the psychotropic medication because जो साइकोट्रोपिक मेडिकेशंस हैं ये मेटाबॉलिक साइड इफेक्ट्स जो हैं वो थोड़ा ज्यादा करते हैं, so that is why all these things needs to be done prior to starting the psychotropic medications and also to rule out any medical conditions. Then gradual dosing and minimizing the side effects. Dosing जो है वो lowest possible dose से शुरू करके then आप थोड़ा थोड़ा रेज करेंगे और ज्यादा रेज करने का जरूरत है, we should refer the patient. Then monitoring and reviewing, अगर अच्छे से रिजल्ट आ रहा है then it's fine, otherwise you just refer the patient. Next. Non-pharmacological approaches, psychoeducation and counseling. I have already told you कि पेशेंट को आप ट्रीटमेंट फार्माकोलॉजिकल ट्रीटमेंट ऑप्शंस के अलावा और भी चीजें आपको साइको एजुकेट करना है कि ये एक साइकियाट्रिक इलनेस है या मेंटल इलनेस है, और अगर आप उसको बताएंगे कि दवाई से ठीक होगा और दवाई के अलावा भी और चीजों से ठीक होगा तो इट रिड्यूसेस स्टिग्मा एंड एम्पावर्स द इंडिविजुअल्स टू एक्टिवली पार्टिसिपेट इन देयर रिकवरी जर्नी. So teach them the coping strategies which usually involves की problem solving skills को समझाए, क्योंकि ज्यादातर केसेस में हमने देखा है कि कुछ ना कुछ स्ट्रेसर या प्रॉब्लम्स होती हैं मरीज के अराउंड, वो अगर सॉल्व उसकी कोपिंग इंक्रीज हो जाएगी तो they can get out of the depression. Then stress management techniques should be taught, जैसे कि progressive muscle relaxation, deep breathing exercises, they can improve their coping. And then the lifestyle modifications and social support should also be enhanced. Lifestyle modifications include dietary changes, regular physical activity, balanced nutrition, adequate sleep, which we need to, sleep hygiene समझाना बहुत जरूरी है. So these things become important in the first line support. Next. Then coming to the last, follow up and referral takers. अगर क्लिनिकल स्टेटस परसिस्टेंट है या वर्सनिंग ऑफ सिम्टम्स हो रहे हैं, एंजाइटी, डिप्रेशन और साइकोसिस ओवर 2 to 4 weeks, देन आप स्पेशलाइज्ड ट्रीटमेंट सेंटर पे उसको रेफर करेंगे. ट्रीटमेंट रिस्पॉन्स, अगर इन based primary care intervention, then you have to refer the patient to specialized treatment center. अगर रिस्क फैक्टर्स आपके ये वाले हैं कि एस्केलेशन ऑफ सेल्फ हार्म आइडिएशंस हो गया या प्लान्स हो गए या फिर जो सब्सटेंस यूज डिसऑर्डर, सब्सटेंस का यूज भी बहुत ज्यादा बढ़ गया है, देन दीज आर द रेड फ्लैग्स कि आपको इसको हायर सेंटर पे रेफर करना है. फंक्शनल इम्पेयरमेंट, सिग्निफिकेंट डिक्लाइन इन डेली फंक्शनिंग, वर्क, सोशल एंड पर्सनल केयर अगर हो रहा है, which is leading to profound functional impairment requiring intensive and specialized interventions. So you have to have referred to the specialized treatment centers or higher centers for psychiatric disorders. अगर आपको डायग्नोसिस का ही अनसर्टेन है, डायग्नोस्टिक क्लैरिटी ही नहीं है, डायग्नोस्टिक अनसर्टेनिटी डिस्पाइट इनिशियल असेसमेंट एंड मॉनिटरिंग, देन यू हैव टू रेफर टू द पेशेंट. जैसे कि बाइपोलर डिसऑर्डर, स्किज़ोफ्रेनिया, they are severe mental illness. Severe mental illness में कई बार प्राइमरी हेल्थ केयर सेटिंग्स में, क्योंकि एटिपिकल प्रेजेंटेशंस भी बहुत सारी होती हैं, तो एटिपिकल प्रेजेंटेशंस में डायग्नोस्टिक डिलेमा होगा एंड वी आर नॉट एबल टू स्टार्ट विद द मेडिकेशंस, देन इट इज appropriate to refer the patient to higher treatment center, specialized treatment center. Next. Then referral pathways, non-response to adequate treatment, acute agitation and serious side effects or suicidal self-harm ideas, And so these are the referral pathways from PHC to specialized treatment centers. Next. I think I have done with my presentation. Thank you all for listening, and sorry for the disturbance in my network.
Thank you, Pratibha. I think, would you be staying with us to take the question and answers?
Yes, sure, ma'am.
Okay, so can we move to Manoj? Is Manoj there? Manoj, are you there? Okay. Ranjit, just check if he's there. Meanwhile, I think, Pratibha, you can take up one or two questions till the time he joins. There was one question in the chat box: how to treat anxiety? How can we treat anxiety disorders at primary level facility?
Okay. Anxiety disorders at primary level. Usually we do not think of the. Hello?
You can,
At the primary care level, we usually do not start with the pharmacotherapy straight away. We need to understand कि anxiety जो है वो कितने time से है और कितना functional impairment कर रही है. So if it is at the mild to moderate level, पहले वही assess करना है कि mild to moderate level पे है, बहुत ज़्यादा functional impairment नहीं हो रहा है, then we have to start with the other modifications, behavioral जैसे counseling हो गया या फिर behavioral modifications हो गया या जो रिडक्शन इन अवॉइडेंस बिहेवियर की ये सब चीजों से या फिर रिलैक्सेशन से progressive muscle relaxation technique, deep breathing is very important, which we usually teach to the patients in the routine care settings. Okay, so these are the things if we see mild, और अगर वो काफी severe level पे है, then we have to start with the, और initially थोड़ा सा symptomatic relief देने के लिए we usually tend to give patients the benzodiazepines, but benzodiazepine prescribe करने के नुकसान भी हैं, फायदे भी हैं. Immediate short term relief तो मिल जाता है. We usually prescribe clonazepam, lorazepam or anything. Short term relief तो मिल जाएगा, but definitely to address anxiety, we have to deal with the avoidant behavior and other behaviors of the patient. So definitely it is only going to give the short-term relief to the patient, anxiolytics. In the long term, we have to go with the other techniques, the non-pharmacological techniques to deal with anxiety. तो आपके पास जितना भी हो पा रहा है वो आप करिए and then refer the patient to the higher centers if you are not able to, or severe anxiety is there.
Pratibha, there is another question: a double SSRI or SSRI plus SNRI, any guidelines and serotonin syndrome risk?
दो SSRI तो हमारे गाइडलाइंस में ही नहीं है कि अगर एक बार प्राइमरी केयर सेटिंग में तो दो SSRI देनी ही नहीं है. अगर एक पे रिस्पॉन्स नहीं आ रहा है और उसकी हायर डोजेस पे जा रहे हैं हम, जैसे कि अगर हमने एसिटेलोप्राम स्टार्ट किया या फ्लॉक्सिटिन स्टार्ट किया, उसको हमने डोज को इंक्रीज भी करके देख लिया और 6 to 8 वीक्स के लिए रिस्पॉन्स नहीं आ रहा है, in any case we say कि भी 6 to 8 weeks तो मैक्सिमम हम देख रहे हैं कि भी इतने में भी नहीं आ रहा है, तो we have to refer the patient. दूसरा ऐड करने का कोई इंडिकेशन प्राइमरी केयर सेटिंग में तो है ही नहीं. दूसरा एडिशन तो बाद में आता है कि अगर हम ऑगमेंट करना चाहते हैं या और कुछ करना चाहते हैं, मतलब ऑगमेंट करना चाहते हैं बेसिकली, या फिर कॉम्बिनेशन थेरेपी करना चाहते हैं, एंड दैट थेरेपी आई थिंक दी स्पेशलाइज्ड मेंटल हेल्थ प्रोफेशनल्स should be doing rather than वो, क्योंकि सेरोटोनिन सिंड्रोम होने के चांसेस आर वेरी वेरी हाई इन, क्योंकि वो डोज को जो है वो प्रॉपरली एडजस्ट नहीं होता है.
Pratibha, I think we have some participants from tertiary care as well.
Okay, that I didn't know,
Around
ma'am.
20%. I was looking at the participants' profile. So we have some tertiary care specialists as well here in the room. So
अच्छा, ठीक है मैम, वो प्राइमरी केयर, आपने प्राइमरी केयर सेटिंग्स वाला टॉपिक
I
दिया
know.
था ना, so I am just
But it's the take-home message actually even for the tertiary care is
yes,
do not double, and if the patient is not
polypharmacy should always be avoided. Polypharmacy should always be avoided. मतलब it is not indicated at all. It is to be done only if की गाइडलाइन, हाँ हमारे पास गाइडलाइन है कि कॉम्बिनेशन थेरेपी भी करना होता है या कहीं पे ऑगमेंटेशन भी करना होता है. डेफिनेटली देयर आर नाइस गाइडलाइंस और देयर आर इंडियन साइकेट्रिक सोसाइटी गाइडलाइंस, इंडियन साइकेट्रिक विच से दैट कॉम्बिनेशन कैन बी डन. लेकिन अगर वो रिस्पॉन्ड नहीं कर रहा है तब then only we proceed to this.
Okay, thank you, Pratima. Manoj has joined us. Hi, Manoj. Can you try? Good afternoon. Can you try sharing your screen? Ranjit, you can introduce him.
Yes, ma'am. Thank you. Thank you, ma'am, for sharing so much information to our participants. Now, we'll start with our next session by Dr. Manoj Kumar sir. He's an experienced psychiatrist and academician, currently working as a assistant professor in Department of Psychiatry at Institute of Human Behavior and Allied Science, New Delhi, since 2010, and he has completed his MBBS from University College of Medical Science and Guru Tegh Bahadur Hospital, then MD in Psychiatry from Central Institute of Psychiatry, Ranchi, and DNB in Psychiatry. With over 2 decades of clinical and teaching experience, he has worked across reputed institutions like ESI Hospital, Okla, and SRMS, Bareilly. He is actively engaged in research with multiple publications in national and international journals, focusing on diverse areas such as bipolar disorder, schizophrenia, ADHD, and neuropsychiatry. He also contributed to ICMR funded research projects and presented papers at national conferences. Dr. Kumar regularly participates in CME programs and conferences, reflecting his continued commitment to the professional development and advancement in mental health care. Uh, uh, I welcome you, sir, and request you to take the session further. I'll
Thank you,
share
Doctor.
your video from our.
Thank you, Dr. Ranjit, for such a wonderful introduction. Now I'm going to take up my session. But before I start with the session, I would like to, because I was just reading some of those messages in the chat box, some of the people are requesting that it should be in English. So, because there are more than 185 attempts present, could you please let me know which language which will be better? Should I use Hindi, English, or English? Some of you can just respond in the chat box so that I can understand that which language will be more comfortable because
I
the
think
audience is
people from all over India are there. Some are good at English and Hindi both, but some may be only English speaking. So if you speak in Hindi, so do some translation in English as well.
okay. Then I prefer to speak in a little bit in English, and sometimes I might be using the Hindi, so it will be more of a English rather than totally English or totally Hindi. All right. So could you please just start my presentation? Show my the slides.
Why there is some background music? Some background sound.
Or maybe my this.
You have to switch off your fan.
Just give me 1 minute.
Yeah, now I think it would be better.
Okay, thank you. Sorry for the interruption. I would like to start with the one particular issue. I was, talking to my friend who was working in Australia. Both of us did the MD from the Central Institute of Psychiatry, and he moved to Australia. So I was talking to him, say, for example, somebody suffering from a psychiatric disorder, how much time he will be, he will be able to get an appointment with a psychiatrist. And he said probably 1.5 years. And I was just shocked to listen to this answer from this my colleague, that today if a person is having a psychiatric disorder, he will be able to have a contact or an appointment with a psychiatrist 1.5 years later on. Similarly, I remember I was listening to one of those videos on the YouTube, and somebody was saying that we live in oasis. We live in a country which is almost an oasis or a Ram Rajya. And I was, initially thought maybe he's, trying to brag ourselves. But later on, when he was, speaking about America, so say, for example, if you suffer from any dental problem, or maybe you suffer from any psychiatric disorder, not before 6 months or so, you will be able to get an appointment with a dentist or a psychiatrist. So the time which is required to have a contact or appointment with a psychiatrist or a dentist is 3 to 6 months in us in America, and 1.5 years in Australia. So initially I thought our system is definitely better because people will be able to walk in. But if a person is having a psychiatric disorder today, he will come in the evening and take a consultation. But you see the countries like America, or see the country like Australia, where there is such a lag period is present, because majority of those cases over there are being treated by the medical officers. And when I try to introspect whether there is any psychiatric disorder which need to be treated only at the tertiary care center, I will say less than 10% need to come to the tertiary care center like IVAS. And majority of these problems can be treated at the primary health care level only. It's that we have not educated our through our MBBS, we have not educated or trained our people, so that everybody who's suffering from a psychiatric problem or maybe minor problems, they eventually will come to a tertiary care center. So this is putting a lot of burden both on the healthcare system, on the person, because every facility or medical facility should be available in the vicinity of a person. So if we can able to educate our medical officers, so it will be very easier for them to start a treatment. It's only those who are not responding to the treatment should be coming to the tertiary or secondary, to the district level, or from the district level to the tertiary care center.
Manoj, can you keep mic closer to
Okay.
your
Okay.
mouth?
So, but the number of the patients, those who are coming to the tertiary care center, should be very less. So with this, objective, I had made my presentation so that the people should be able to, identify, and then they can start the treatment. It's only those who are not responding to the treatment, or if there is something which is requiring, tertiary care center treatment, they should be coming to us. So with this objective, I'm going to start my presentation, and I will try to be slightly, brief, because already we are running short of time. So next slide, please. So before actually I start my topic, it is very much important that my audience and I am at the same page. So for that one, it is very much important that the people should be able to understand the terminologies which we are going to use, because unless or until the terms that I am using, if you are not able to understand them, it will be very difficult to comprehend. So next slide, please. So I will be talking about some of those terminologies which are being used. So I will be talking the terms like drug. What is a drug? What is a substance? What is dependence? What is addiction? What is psychoactive means? What is dependence criteria? What is screening? And what is assessment? So I start with what is drug. Next slide, please. Next slide, please. Thank you. So drug means any article other than food which is intended to affect the structure or any function of the body. This can be a prescription drug, over-the-counter medication, or any drug in the powder or tablet or syrup form. That is called a drug. Next slide, please. Whereas substance is actually a drug plus any natural substances like tobacco, bhang, etc. So these are not available in the over-the-counter. So what we basically trying to say is drug is something which is being prepared in a factory, which is in a chemical form or in a tablet form or in a syrup form, which is available over the counter or written by the doctors. But some of those products like tobacco or bhang, these are natural products which can be taken by the person from the jungles and other places, and they can be used. So substance is a broader term in comparison to drug. So essentially all drugs are substances, but all substances are not drug. Next slide, please. So drug abuse, what is the meaning of the word abuse? Means drug abuse refers to the use of drugs in the excessive amount. So when a person is using this in excessive amount, then it is called as drug abuse. And what is dependence? Dependence is a terminology which is used more by the psychiatrist, and it means the person has lost a sense of loss of control of drug use. The body requires a drug or substance for the function. Means without the substance, the person is not able to work. That is called dependence. Now there is one more term which we use, which is called addiction. Next slide, please. Next slide. Addiction is a disease of the brain reward center leading to loss of control of drug use. So we use two terminologies. One is a dependence, which is more used by the psychiatrist, and addiction is a one terminology which is being used more by the neurologist. And when they say addiction, we are trying to say that it is a disease of the brain. Whereas a dependence is a term which is being used by the psychiatrist when we say that without the substance the person is not able to work. That is called dependence. Now there are certain criteria to determine whether the person is dependent on the substance or not. Previous slide, please. Previous. No. Yes. So when we say the dependence, at least 3 criteria out of these 6 should be present. 3 or more criteria should be present to call it as a drug dependence. Now, what are these criteria are? There is an intense desire to take the substance, difficulty in controlling either the initiation, level of use, or the termination. There is a physiological withdrawal state is present. There is evidence of tolerance, neglect of other pleasurable activities, and persisting with the substance despite the evidence of harmful consequences. So out of these 6, if 3 or more are present, then it is said that the person is dependent on the substance or the drug. Now, using these criteria, if you will observe that internet dependence or internet addiction, is it a true phenomena or not? If you will see these criteria in properly, you will realize there is an intense desire. There is a difficulty in controlling either the initiation, level of use, or the termination, and there is a neglect of other pleasurable activities. So these 3 criteria are meeting. That means we can say that internet addiction is a true diagnosable entity, and it is almost the same as drug dependence. Now, next slide, please. Next. Now, there is one more important, because our topic is related to screening and assessment. So screening means we are evaluating the possible presence of a particular problem. When we are saying screening, it is evaluating the possible presence of a particular problem. The outcome is normally a simple yes and no. So when we do large-scale screening, it is only whether the problem is present in the society or not. Assessment refers to defining the nature of that problem, determining a diagnosis, and developing a specific treatment recommendation for addressing the problem or the diagnosis. So screening is just yes and no, and assessment is a comprehensive assessment of the person to diagnose and treat that person. Next slide, please. Now, why there is a need for screening of substance use is important. Now, it is important because the persons who are at a risk of developing the substance, whether there is a large number of people who might be at a risk of developing the substance dependence, identifying the patients who need the further assessment, and any use, for say, for example, during the pregnancy, driving, or working, somebody who is working with machinery while taking the medication that may interact with alcohol or medical condition, for example, hepatitis C, lung cancer, or COPD. So it is important that whatever the medication that we are prescribing to the patient, we should also be knowing whether they are taking any other drugs which can have an interaction, which can have an interaction and cause complications. So screening and brief interventions can promote a significant reduction in the alcohol and tobacco use. Next question. Next slide, please. Now, coming to the assessment. When we do the assessment forms the first point of contact for the clinical staff with the client. And why the assessment is done and how it is done, let's discuss this. Next question. Next slide, please. Now, when we do assessment, there are 3 stages of assessment. First, we take a clinical history of the patient. Then we go for the investigation, and then there are certain instruments to validate as well as quantify what is the level of the problem is present. So the assessment will have 3 stages. First, we will take a proper history. Then we will go for the certain investigation, and then certain instruments will be used to monitor the severity, as well as during the treatment also we can use those instruments when the person is showing improvement. Next slide, please. So we start with the clinical. So when a clinical assessment is started, it means there is interaction with the patient and the client. There is an interaction with the family members or companion. The physical examination is done, and the previous treatment records are taken. Next slide, please. So when we take the clinical history of the patient, we first of all should collect the social demographic profile of the person. We should know the name, age, sex, marital status, qualification, occupation, type of family, place of residence, identification mark. So all these parameters should be there in our record, so that we can able to trace this person in case of the follow-ups of these patients. Next slide, please. Now, then subsequently, after taking the socio-demographic profile of the patient, we take the clinical history. And this, in the clinical assessment, we will ask the following questions, like what is the age of initiation, what is the frequency of drug use, what is the quantity of drug taken usually, what is the time lag since the last dose used, whether the person has any developed tolerance, whether the effect of the use of a particular drug and the signs and symptoms of intoxication are present in the person or not, whether the person is showing any withdrawal symptoms currently, and whether the craving is present in the person or not. So this is how we take the clinical history. Then also, besides this, we should also ask the complications which are associated with the drug. Say, for example, physical complications. So usually those who are IV drug users, they might be having thrombophlebitis. They might be transmitting the HIVs and other things. So when we are doing a physical examination, we should be also looking for all those say, for example, thrombophlebitis, or there is any ulcers are present in the body or not. So we do the physical examination. Similarly, to identify a person who is a opioid user. So if you will see there, the tip of the thumb, index finger, and middle finger are usually burned because they are using this opioid through the process of chasing. So even if the person is not telling, you can just do the physical examination and can identify. Similarly, there are physical signs of alcohol use. Similarly, there are signs of the tobacco use. Then we should also ask about the psychological complications associated with the substance use. Then we should also know about the financial problems, occupations of the person, or whether there is any occupational loss has occurred or not. And then whether it is familial in the familial means whether it is running in the family. Other members of the family are also taking, maybe with the parents, or maybe the brother and the sisters are also taking. And then any legal complication which is arised because of this substance use behavior. Next slide, please. Then high risk behavior is also very important to be identified at the level of primary health care level. Now, whether there is any needle use practices present in the person, whether there is a sharing of needle has been done, whether there is a sharing of syringes, cotton, vials, or other paraphernalia, then what are the cleaning practices that the person was using, whether there is any use or reuse of needle and syringes, whether the person is having any knowledge of HIV and AIDS. So all this will form the part and parcel of clinical assessment. Next slide, please. Similarly, actually, it was also important when we are planning for a treatment of a person who is substance dependent. We should also be asking for the past treatment. So past treatment will include whether he has made any attempt to stop the substance, what was the duration of each attempt, what is the reason for abstinence, because many times we have seen in the cases of alcohol or opioid, so whenever the drug is not available, the person will stop. Or say for example, in the cases of alcohol, whenever there is some religious month will come, say for example during the period of July. So in the North India, the people will stop taking alcohol, and suddenly they will develop the kind of the withdrawal symptoms as a DT, so which can increase this frequency. Similarly, for say for example during this Holi festival, there are a lot of people might be taking the cannabis. So we have seen the increase in the sputter of the cases of cannabis use during the Holi. So whether the treatment which the person was taken in the past, whether it was only harm reduction or it was a complete abstinence he has tried, what was the nature of the services sought. And sometimes it has been seen that many people, those who are suffering from substance use, are being taken to these private de-addiction centers, where the person is not actually given any treatment, and they're being kept inside a room and locked from outside. So they remain over there for months, and then after that they are released. And after the release from those de-addiction centers, their first thing is they will go and take the substance. It's because they were locked. There were no actual treatment was given to them in those de-addiction centers. So next slide, please. So the further we should also be asking, because comorbidity is a very common phenomena in patients with a substance use disorder. So we should be taking the psychiatric illness, any history of depression. So people, those who are suffering from depression might be taking this alcohol very commonly. Similarly, those who are having an anxiety disorder might be taking this alcohol. So this alcohol is also being taken because of the sleep problem, because of the depression, or maybe there is some kind of stress is present. So we need to identify these psychiatric illnesses in the persons, which might be acting as a perpetuating factor in substance use disorder. Then we also have to take the family history of the drug use, uh, the, the current living arrangement of the person, the social support of the person, and reason for seeking the treatment currently. Next slide, please. Then we have to do in the first stage we have taken the history. Now the second stage is we have to do the physical examination of the person. So this physical examination should be aimed at knowing about any signs of intoxication, whether there is any signs of withdrawal are present or not, what is the route of the drug the person was using. Accordingly, there could be signs and symptoms. There could be some stigmata might be present around that part. So say for example somebody is using the injectables, so there will be some thrombophlebitis might be there. Or if say for example somebody is smoking too much, so there will be the coloring discoloration of the teeth will be present. So we should be knowing about the route of drug use. Then evidence of any physical damage due to the drug use. So many people, those who are taking alcohol, might met an accident. So accordingly, when we take the history, if they are having a fractures or they are having some kind of deformities, when we ask them, they will tell that during the intoxication they met an accident and other things. Then we also have to do the systemic examination to rule out any possibility of portal hypertension or liver cirrhosis or hepatomegaly or splenomegaly. This is also important in the patients of substance use. Next slide, please. Next slide, please. Now, the further assessment will, which includes investigation, is there are two types of investigation. First, to assess the degree of the physical damage. So this will include hemogram, LFT, renal function test. We also have to look for the HIV, hepatitis B and C, and to confirm the presence and absence of a drug in the body, we might be using the screening. Means sometimes the patient might underreport that they are not taking the substances. So for that one, we might have to go for the screening. So we have UDS, urinary drug screening, which may detect up to 12 substances the person might be taking. So this is a kind of UPT type of kit is present. The person urine sample is taken, and all those substances the person might be taking will become evident using those strips. Next slide, please. Now, there are certain structural instruments are also being used to know about the severity or the comprehensive assessment. So structured set of questions are there, and they act as a validated assessment across time, place, and person. So examples of these type of tools are addiction severity index, clinical opioid withdrawal scales, cage questionnaire. Next slide, please. Next slide. So like this is one of those tests which can be used at the primary healthcare level, drug abuse screen test. So this contains 10 questions which are the answer of which are given in the yes and no, and this will help in overall assessing the person's drug use. Next question. Next slide, please. Next slide. Like this is a drug abuse screen test. So all these this just scales that I'm showing is available freely on the net. So if somebody wanted to use these, they can able to download from the net and can use in their clinical practice. Next slide, please. Next slide, please. Then there is a National Institute of Drug Abuse. So this is also used for screening. This is a screening tool. It contains questions about how often you use the prescription drugs, illegal drugs, tobacco, and alcohol. There is one multiple choice questions for each substance. The answer range from never to daily. And if you use any of these substances more often than never, it means you have a substance abuse problem. So this is also one of those screening tools. Next slide, please. This is NIDA. Next slide, please. Next slide. Then we have modified NIDA, which is used for alcohol, smoking, and substance involvement screening. So basically, there are so many structured tools are available which will help us in knowing about the pattern of substance, the type of the substance, and the pattern of substance use. Next slide, please. Then this is a cage questionnaire. This is very frequently used for the alcohol use. So in the cage questionnaires, there are if the two or more are present in the person, then it indicates that the person is dependent on a substance. So cage stand for, C stand for cut down, A for annoyed, G for guilty, E for eye opener. So the questions are, have you ever felt the need to cut down on your drug use? Do you ever feel the need Do you ever feel annoyed when the people criticize your drug use? Have you ever felt embarrassed or guilty about your drug use? And eye opener means, have you ever used drugs first thing in the morning? So out of these four questions, if two or more are found to be positive, that indicates that the person is in the need of a comprehensive assessment and further treatment. Next slide, please. Then this is craft questionnaire. This is car, relax, alone, forget, friend, trouble. So this test is used for teens and include the following yes and no questions about drug and alcohol use. So this is especially for the teens. Next slide, please. Then we have a types. This is very frequently used in our clinical practice: the tobacco, alcohol, prescription medication, and other substance use. So the scope of this is tobacco, alcohol. So many of these, this instrument that I am talking may not be able to pick up the tobacco, but here it is also used for tobacco, prescription drugs, and other substances. Next slide, please. This is NIDA and TAPS. Next slide. Continue. Next slide, please. Now, finally, we come to the diagnosis. So we have taken the history, we have done the physical examination, and we have done the assessment of the person using some screening tools. So after taking this comprehensive history, physical examination, now we make the diagnosis. Now the diagnosis is made under the multiple headings. So next slide, please. The diagnosis will be of the primary drug. Primary drug, that means the drug for which he has come to us. Secondary drug use, maybe the person might be taking certain drugs for which he is currently abstinent, but he has taken those drugs in the past. Then there are what are the psychological morbidity which are present in the person, which are contributing to the continuous substance use. The physical comorbidities which are present in the person, which might be either the cause or which is leading to development of substance use disorder. Say for example, somebody suffering from cancer, or somebody suffering from osteoarthritis might be taking the opioids to relieve the pain, but ultimately in the long run they become dependent on opioids. So if there is any such physical comorbidities present, we document that. And then the psychosocial issues like financial issues, legal issues, which might also be contributing to the relapse in the person, we make the diagnosis under these headings and identify it. And because the diagnosis is made under these headings, accordingly we will plan for the management of the person. So it is not only the pharmacological medication that we will plan for management of the patient with the substance use, but rather we will use a comprehensive psychological, social, other psychiatric. So this is a comprehensive management plan for the patients. Next slide, please. Now coming to some specific substances. So first of all, we talk about the nicotine use. So these are the nicotine leaves that you can see. Next slide, please. Next slide. Now, why I started with the nicotine? There is so many reasons to start with alcohol, opioids, and other higher order substances. But actually, the people are not able to understand the largest amount of the substance which is being used by the society is tobacco. The number of the people those who are taking alcohol in comparison to tobacco will be lesser, and those who are taking the opioid in comparison to alcohol will be lesser, and those who are taking the cannabis will be lesser than the opioids. So you can see this is a kind of a pyramid. In the pyramid, the lowest portion is the nicotine, and gradually it is reducing towards apex, and the number of the people who might be taking a very hardcore substances, maybe like cocaine or LSD, they are very less in number in comparison to the nicotine, alcohol, or opioids. So this nicotine or a tobacco is one of those which is causing the large number of complications in terms of the medical complications which is arising in the society, and yet it is not been given due importance in identification and treatment. So the global burden of this tobacco This tobacco kills nearly about 6 million people, and nearly 80% of these deaths occurs in the low and middle income countries. Next slide, please. The above number of death includes 6 lakh deaths from the second-hand smoking. So smoking is not only kills the person who smokes directly, but also those who comes in the vicinity or contact with this person are also at a risk of developing these complications and death. Next. Unless the urgent action is taken, more than 8 million people will die annually from tobacco by 2030. So maybe the diagnosis will not reflect correctly that the person has died because of tobacco. It might be written that the person has died because of the cardiac complications, or maybe the respiratory problem or emphysema. But the underlying cause of all these deaths might be attributed to the tobacco. So average person who smokes will die about 8 years earlier than the similar non-smokers. Means if you will see any insurance policies, if you see any insurance policy, they have always mentioned whether you are a smoker or not. So if you are a smoker, your premium will be slightly higher than the person who is a non-smoker. That means it is very known fact, and there is nothing hidden, that the people those who will smoke will definitely die at least 8 years earlier than the people those who are non-smoker. Next slide, please. Now, if you see the composition of a cigarette, the composition of cigarette is it is a mixture of the tobacco smoke is a mixture of gases and the fine particles, which contains nearly about 5,000 toxic chemicals, and about 70 of these chemicals are found to be carcinogenics, and the dependence on the tobacco is due to the nicotine. So actually, if we really analyze this in detail, we realize that the nicotine might not be that problematic, which this smoke is. So this smoke contains many carcinogens which are going through the smoke to inside the person through the lungs and then absorption. So nicotine per se might not be that problematic. It is a smoke. So this smoking need to be reduced. Otherwise, the people will die because of these the toxic chemicals which is going through the smoking. Next slide, please. Now, coming to the goal of smoking management, means basically when we plan for the smoking management, automatically we have to go through the same process of, first of all, we have to take the history, then we have to take the assessment, and then we have to do certain, the test has to be applied to understand the pattern of the substance use. So once we have done all this and the person has acknowledged that he is having a problem related to tobacco use, then we have to plan for the management of this person. Next slide, please. So in the pharmacotherapy should be offered to all the smokers trying to quit except where contraindicated. Means it has been seen that many of these substances the person might be put into a say for example put into a room and locked from outside, and till the time the person will remain in that room, automatically he will not be able to take any substance, and he will be free. But this tobacco is one product for which the pharmacotherapy is definitely indicated, because the craving which arises because of the tobacco is very, very severe, and this craving cannot be managed only by putting a person in the lock and key. Next slide, please. So these are the 7 options which are available either in India or maybe in USA also. So these are the only 7 options. The one is a nicotine patch, nicotine gum, nicotine lozenges, nicotine inhaler, nicotine nasal spray, bupropion and vanacin. So there are 2 medications, and then we have a nicotine gum and nicotine patch which can be readily available. Many of these other options like nicotine lozenges, nicotine inhaler, or nicotine nasal spray might not be that frequently being used. But in the primary health center, these nicotine gum, patch, and bupropion and vanacin can easily be written, and there is no need of any specialized training or education is required regarding this. Next slide. Next slide, please. Now, nicotine replacement therapy. So by giving the NRT, it reduces the withdrawal symptoms, it reduces the craving, it delivers the nicotine without toxins from the tobacco. So automatically the government has realized actually it is not the nicotine which is the problematic, it is only the smoke which is going inside the person which is causing the problem. So as a result, the nicotine replacement therapy, which includes nicotine gum and nicotine lozenges, the promotion is there that the people should be using more frequently this rather than using the cigarette and the BBs. Next slide, please. Now, when we talk about the nicotine replacement therapy, there is no evidence that the nicotine causes cancer, whereas the smoke does. So there is no evidence of increased cardiovascular risk with the NRT, and the medical contraindication for NRT is only immediate myocardial infarction, because there can be increase in there can be tachycardia. There could be serious arrhythmia if the person has, then it is contraindicated. If the person is having a serious or worsening of angina pectoris is present, then these NRT is usually avoided. Basically, the palpitation which can arise because of this NRT, uh, because palpitation is happening, the person is having MI, if the person is having arrhythmias, that can get further accentuated and the person can have complications. Other than this cardiac complication, there is very less the side effects of the nicotine and nicotine use therapy. Next slide, please. Now, nicotine patch, how it is being used? There are, the patches can be, one patch can last up to 24 hours. So they are available in the strength of 7 milligram, 14 milligram, and 21 milligram. It is available over the counter, so there is no special prescription is available. The person can go to the shop and then buy this nicotine patch, depending on the frequency or the number of the cigarette the person was taking. Next slide, please. The nicotine gum, there are two strengths are available in the market, 2 milligram and 4 milligram. 2 milligram is more commonly used for the people, those who are smokers, and 4 milligram is used those who are chewers of tobacco. But it is also being seen that if the person is smoking less than 25 cigarettes per day, then 2 milligram is suffice. Though the number of tablets which the person might be using is more, and 4 milligram is used if the person was using the cigarettes more than 24 per day. Next slide, please. Now, bupropion is one medication which is found to be of use in the nicotine in the tobacco dependence, and how it is being given. One tablet per day is given, and usually after the drug will start showing its effect by 3 weeks. So once the medication is started and 3 weeks has 3 weeks has passed, then now what we can do, we can ask the person to taper his tobacco use. So as a primary healthcare physician, you can start the bupropion 150 milligram. It is available both in the tablet and the capsule form. So you start today. After 21 days, when the patient might be showing some effects because of the bupropion, do you ask the person to reduce the nicotine or the tobacco use, smoking and BD use. Next slide, please. Next slide. This is one more medication. These bupropion and varnacillin are the only two medications which are available internationally for the treatment of tobacco use. So varnacillin, the only problem with this varnacillin is highly expensive. So it is available in the form of 0.5 milligram and 1 milligram. So it usually started with the 0.5 milligram, which is available in the starter patch and starter pack, and it is used for nearly about 1 week, and subsequently you can increase from 0.5 to 1 milligram. So 0.5 milligram is given for 3 days, then 0.5 milligram twice daily for 4 days, and then subsequently 1 milligram twice a day is used. The only problem with this varnacillin is it's highly expensive in comparison to the bupropion. Next slide, please. Now coming to the alcohol use disorders, so you all know about, because alcohol we have read about previous slide, please. Alcohol we have already know about, the people might be, large number of people might be taking the alcohol, but one of the most important side effect of alcohol withdrawal is the delirium treatment that we should be knowing. If a person will stop taking the alcohol and after nearly about 3 to 4 days, usually they might go into a delirium tremens. So this is one of those medical complications which you should not be treating at a primary healthcare level, because it has the symptoms of autonomic instability, and around untreated delirium tremens can lead to death in approximately 20% of the patients. So delirium tremens is a medical emergency which need not be treated at the primary healthcare level, and it should be sent to the health the higher centers. And at maximum, what you can able to do at the level, your level, you can give the thiamine to the person and give the lorazepam doses to reduce this autonomic instability and cause mild sedation in the person. Next slide. Now, when we come to the screening of the alcohol use in the primary medical center, this is one of the very easiest way to use the the cage questionnaire, which contains the 4 only items, and if 2 or more are present, then it is the alcohol problematic use is present in this person. Other than this, there is an audit scale is present. So this is audit means alcohol use disorder identification test. It is more sensitive and specific than the cage questionnaires. So it is a little bit of slightly lengthy in comparison to these cage questionnaires. So if you want to monitor the progress of the person, then we can use the audit scale. Next slide, please. Next slide, please. Now coming to the treatment of alcohol dependence. So in the treatment of substance dependence, rather than alcohol dependence, in the treatment of substance dependence, there are two phases. The first phase is when you will immediately stop the person from taking any substance, there will be withdrawal symptoms will occur. Now these withdrawal symptoms can be of two types. One is physical withdrawal symptoms and other is psychological withdrawal symptoms. So it is a physical withdrawal symptoms which requires some medication, and if you will not give the medication, there can be serious complications. So the first stage, usually we call this, when we are managing this physical withdrawal, is called detoxification. And the second stage is relapse prevention. So during this detoxification, the drugs which can be used for the alcohol withdrawal, usually say for example, you are sitting in a primary healthcare center and the patient says, I want to quit alcohol. And then rather than sending the patient to the higher centers, you can say, you can start the medication to the patient like in the form of benzodiazepines. So the most frequently which is used benzodiazepine in the management of alcohol withdrawal for detoxification is lorazepam. So you can start from 2 milligram, titrate up to 4, 6 or 8 milligram, and then subsequently gradually reduce it also. Along with that one, you can give the thiamine to the person. So these are the two things which you can do at a primary healthcare center level, and this will take care of many of the the withdrawal symptoms the person might be having because of the alcohol. The second stage is the relapse prevention. Next slide, please. Next slide, please. So drugs which is used is benzodiazepines. So benzodiazepines, we have chlordiazepoxide and diazepam and lorazepam. Lorazepam is more frequently available because you might be using it for the other purposes also. So lorazepam is very commonly used. Otherwise, we can use the chlordiazepoxide or diazepam also. Next slide, please. So once the detoxification has been done, we wanted to prevent the person should not relapse. So to prevent the relapse, we have two types of agent. One is called as deterrent agent and second is called anti-craving agents. Deterrent agents are those agents which will deter the person from taking the alcohol in the future. And the drug which is under this category, which is available in the market, is disulfiram. So many of these, these Ojas and Pandits and other people, those who are doing management of substance, they are using this molecule disulfiram. They will mix it into their, the food, maybe in their drinks. And when the person will take alcohol, there will be disulfiram ethanol reaction will occur, in which the person will have flushing and they might be having palpitation, perspiration. So as a result, the person will, get scared, and he will say these. Maybe this is the water in which it is being given to the person, or maybe the food, or maybe some bahut it is being given to the person. So they will deter the person from taking the alcohol again. But usually this disulfiram in a setting like primary health care center, we should not be giving to the person without their knowledge, because it can cause a complication if the person has taken alcohol accidentally and he's not aware that he was on a disulfiram. There could be severe alcohol disulfiram ethanol reaction can occur in the person, which is a medical emergency, which also need to be referred to the higher centers for the management. The safest is we use anti-craving agents. So by using the anti-craving agents, we can reduce the craving in the person to take the substance. So the most commonly which is being used is naltrexone, topiramate, acamprosate, SSRIs like fluoxetine and baclofen. So these are some of those molecules which can be used even at the primary health care center. Once you have treated the person for 10-15 days for detoxification, subsequently you want to prevent the relapse in the person, so you can start using naltrexone from 25 milligram to 50 milligram, maybe once in a day. Then topiramate from 10 to 200 milligram. A compressate is used in the doses of 333 milligram 3 times a day. So then SSRI is like fluoxetine and baclofen. So all these, these molecules are very limited in number. You don't need to go through, you need very long duration of, educations to treat these patients. So disulfiram generally is not being encouraged, because without the knowledge of the person, if you are going to give, there can be problems. So best is we use anti-craving agents. You can use naltrexone, you can use topiramate, you can use acamprosate. Next slide, please. Next slide, please. Next slide, please. Naltrexone. Next slide, please. Next slide, please. Next slide, please. Now, sometimes actually when a person is, taking the treatment from you, you might be wanted to know whether the person is actually following your instruction or not. So we may use the screening tools that we have used. Say, for example, we have used audit in the cases of alcohol use disorder, or otherwise we can ask the person to go for certain biomarkers. So one of the very commonly used biomarker to say whether the person was taking alcohol or not is the GGT, gamma glutamyl transferase. So you ask the person to go for a LFT with GGT. If the GGT is more than 30 units per liter, that means he is still taking the alcohol. And if it is less than this 30, that means the person is currently abstaining from alcohol. Next slide, please. Now, there are certain non-pharmacological treatment which you can do at the primary health center level. It need not to be done at a very specialized centers, and there is no special training is required for this. So one is individual psychotherapy. So individual psychotherapy is done depending on the level of the motivation the person is having. So there are 6 stages of motivation. The first is the pre-contemplation, where the person is not at all motivated. Second is the contemplation, where the person is motivated but it is still denying. Sometimes there is ambivalency is present. Then determination, that the person is ready to participate in the therapy. Action means the overt behavioral steps are taken by the person. Then maintenance, and then relapse. So after these 6, if you identify that the person is in the contemplation phase, then our psychological intervention should be that he move from contemplation to determination phase. So for to do this, we have motivation enhancement, interviews, and which is done on the principles of DARES, and the DARES stand for develop the discrepancy. Usually, say for example, the person is in the ambivalent state, and he says that actually I wanted to give alcohol, but maybe because of this reason or that reason, I don't want to continue. I don't want to give up. Rather, I want to continue. So your first step will be develop the discrepancy. And say, for example, you tell the person that you are taking alcohol and your blood parameters are so much deranged, and there is a need that you should give up. So when you develop the discrepancy in the mind of the person will be ready to accept. Second is avoid argument. Never do an argument with the person who is not at all motivated. The third is roll with the resistance. The person will show the resistance, but you have to continue with this. Express empathy, and then self-efficacy. So the DARES is a very commonly used principle uh, for the motivation of the people, those who are taking substances. Next slide, please. Then there is one very important concept in alcohol use disorder. This is called Alcoholic Anonymous. Now, because it is anonymous, so there is no promotion of these groups will be there. Rather, these are the groups which are present in almost every country. There are more than 200 countries. It is present. It is present in India. It is present in the majority of the major cities, in the smaller cities. But the only thing is they are anonymous. So they will. These are basically a group of people, those who are they have given up substance, and they motivate the other person also to stop. So even the American Association of Addiction Medicine has recognized that whatever the kind of the pharmacotherapy that we give to the person, it is better that the person should go back to these groups, because these social group will be able to do much more justice with the patient rather than only the pharmacotherapy. Because many people take those who take the substances, if they are not having any comorbid psychiatric disorder, it is ultimately the social gathering in which the person will be taking. So for these people, this group is important. Next slide, please. Then we have an opioid use disorders. Next slide. Next slide. Next slide, please. So it is important actually when a person might be coming to you for opioid. So they might be having intoxication, or they might be having a withdrawal. So in the intoxication, the person might have analgesia, constipation, pupillary constriction, and during the withdrawal phase, person might be having all you can say, remember in this easiest form, that all secretions increases during the withdrawal state of opioid. Next slide, please. So how we are going to treat the people, those who are taking the smack. So for usually the people, those who are coming with a smack, we can give the buprenorphine when a person wants a substitution rather than a complete abstinence. So we have non-opioid drugs like clonidine. So it is better at your level, you should be using the buprenorphine. But the important thing is that the person should not be taking these medications, because he might be selling those and can increase the misuse of these medications at your level. Next slide, please. So for the long-term maintenance, we have to use buprenorphine maintenance, or we might be using the methadone. And this is a technique which is called as harm minimization. Usually it has been seen that if a person is taking the substance for a very long time, it is very difficult to give up. So the best is, rather than complete abstinence, we think about harm minimization. Like, say for example, if the person stopped taking smoking, and if we are giving a nicotine, that is better than continuation of smoking. Similarly, if the person was taking this this injectables opioid, it is better to give a buprenorphine medication rather than spreading this spreading through the injectables, which is causing the hepatitis and HIV. Next slide, please. Now there is one more approach. This is called screening, brief intervention, and referral to treatment. So first of all, we do the screening, we do the brief intervention, and if, say for example, still we are not able to treat that person, there's always a higher level of center is available where you can refer this person. Next slide, please. Now coming to the preventive strategies. So once we have know that this is the treatment, this is how we can able to treat at our level, but if still there is further support is required, we have a certain backup plans. Next slide, please. Next slide, please. There is something called Nasha Mukt Bharat Abhiyan. So Drug Free India campaign. This is a national initiative targeting 272 districts across India, and because there is a high prevalence of substance use in India, so this campaign is going on. Next slide, please. Now, how we are preventing the substance use? On the festivals, there are dry days. The last day of every month is a dry day for tobacco. Next slide, please. Next slide, please. Now, how to deal with the stigma? Sometimes the people might not be ready for treatment. So healing begins with the self-acceptance. Unless or until the person will not accept that he is having a problem of substance use, he will not be treated. So it is important that we should encourage the person to accept it and start taking the treatment. Now, sometimes it may happen that the person is ready to accept, but he is not willing to come for the treatment. So for that, we have a teleconsultations also. Next slide, please. Now, these are the free teleconsultation numbers like 14416, 14446. So these numbers are for alcohol as well as for tobacco, where the person can call and take the help. Both psychological interventions is being done, counseling is done, so that the person can give up the substance if he's not willing to come forward and taking the help in the hospital or primary health care level center level. Next slide, please. Now, there is one of those initiatives which the Modi government has started. This is called Telemanas. This Telemanas is available 24/7. It is available in multiple languages, where the person can call these numbers and take help. It is both for substance use as well as for psychiatric disorder. So if the person is believe that he doesn't want to go to a psychiatrist or any mental health institution or any other place, and do not want to reveal his problems of psychiatric disorders or substance use, you can just call these toll-free numbers and can take help. Also, if you need any help, if you're sitting in a very remote place and you want some kind of a guidance regarding the management of these patients, you can call these numbers and you can take help. Then there is also Nasha Mukt Bharat Abhiyan with this telephone number 14446. This is also a toll-free number where you can approach, the patient can approach and take help. Next slide, please. This is for alcohol and drugs. Then there is a National Tobacco Quit Line Service. The number is given on your screen. So this is totally free of cost. Next slide, please. Next slide, please. The other resources like Alcoholic Anonymous. Previous slide, please. Alcoholic Anonymous, Alateen groups, Al-Anon family groups, Narcotic Anonymous. So Alcoholic Anonymous is that I have told you, it is for the people, those who have recovered from alcohol. Alateen group is for children. Sometimes, if a person with children is around 15, 16, they have become dependent on substance, then they can go to these Alateen groups rather than Alcoholic Anonymous, where the adults are present. Then Al-Anon family groups means the people, those who are taking substance are not the only one who are suffering. It is a family who get disturbed because of the substance. So if the family needs some kind of support, there is Al-Anon family groups are also present. Similarly, similar type of resources are available like Narcotic Anonymous, where the people those who are given narcotic drugs, they just meet and encourage the other person to stop taking the drugs. So with this, actually, I stop here. Thank you for your patient listening. And if you have any questions, please do ask.
Thank you, Manoj. This was an exhaustive topic, and I was listening to you. There are plethora of screening tools that are to be used for screening these substance use disorders. And I was wondering, how far people at primary care would be able to use all of them. Should they know all of them? So are there any specific messages that you would like to give while using these screening tools? Any precautions to be taken when you are using these screening tools?
The best thing is actually, when a person comes to us with a substance use disorder, they will readily accept it. That I'm taking tobacco, I'm taking alcohol, I'm taking opioid. So there is no need for applying a screening tools. Only the thing is when you want to monitor, quantify, because there can be some legal complications. When you are treating a certain patient, we have to have a proper documentation that I was treating this person was having this kind of problem. So it is only for the safety, but otherwise, in a sense, in a large part of a country, we don't need any screening tools. We can just, if the patient is ready to accept that he's taking the substance, that is more than sufficient enough. We don't need any tools like these screening tools that I discussed in my presentation.
What kind of medical legal problem will happen if you don't, screen and document?
Let's say, for example, the screening may not be that important. It's only the assessment of the person. So, say, for example, the person was being, sometimes the family come to us, the doctor, whatever the medication that you have written, the patient is not taking, and we wanted to give the medication covertly. So, say, for example, disulfiram is given to the person, and if we have not documented, then there is a problem. If the person develops a serious complication, he will sue us.
So I think one take-home message is, if the patient is admitting, you don't need it, you need to use screening tool. But when you use screening tool, but it is not equal to diagnosis.
Yes, madam.
So don't conclude that or label that person as addict. That these are, and then while conducting these screenings, must ensure that privacy and confidentiality is maintained, and use culturally and linguistically relevant or appropriate versions. Are these available? Where can they get these screening tools?
So whatever the screening tool that I have told you, these are very basic in nature, and they, just type on the Google, you will be able to get all these which I just given. Because some of those specific need some approval, but these tests that I told is freely
available. Are they available in the public domain? Where can
yes, ma'am. Yes, it is available in the public domain. Yeah.
Okay. Then also, while using these, do consider comorbid conditions and the acute states. Don't do it when they are in severe pain or withdrawal state or in intoxicated state. There are few safeguards that you need to apply while using this. Regarding overall, I think if we go into the individual management, it is these are sessions in itself. But anything you would like to tell the participants here? What are the key principles that are followed?
Say, for example, actually, as far as the substance use is concerned, I think because number of the psychiatrists in India are so less that it has to be taken up by all the medical officers. So the treatment can start at your level. It's only some of the very serious conditions like delirium, when the person is having portal hypertension, that needs the referral. Otherwise, all these nicotine, alcohol, opioid can be easily be managed at your level. So whatever the medication that I have described, you can write down. You are authorized to write and start the treatment. And similarly, actually, without talking to the patient, without informing the patient, without telling that if you're taking these medication, if you take the substance, there could be some problems can arise. So brief intervention. It has been seen that if you will just talk to the patient for 2 minutes, it is suffice. It has a significant impact on the patient's overall psyche. So you don't need any specialization. Just talk to the patient that you need to give up. This is causing the problem. If it is not causing the problem today, there may be a problem maybe after 2 years, 5 years, or 10 years down the line. So at that time, when you will ask for the treatment, say for example, once the cancer is developed, what is the treatment? So it is important that we should be talking with the patient, and giving a brief intervention of only 2 or 3 minutes has shown a significant improvement in the outcome of the patients.
Many times, family members, the patient does not come forward. He's an alcoholic, and it is affecting social life and other things. So they come and ask for it. Is there anything that we can do this? Or there are advertisements like, come to us. We will 5 doses. We will, take care of the addiction problem and all that. What is your experience about this?
As far as actually the this promotions which is concerned about the substance use, there is no promotion is being allowed. But regarding this treatment, of course, there are people are saying that we can able to treat, but ultimately they are putting the person in a room and they will lock it from outside, and they will believe that the treatment has been done. So that is not the treatment. The second problem is actually when the family is actually suffering and the patient doesn't want to do come for the forward for the treatment. And in those circumstances, that stage is actually addiction stage. It is no more just an abuse or a dependence. It has gone to a level that it has become a disease of the brain. And at that time, either we take the help of the family members or the relatives or the neighbors, or if it is required, we might have to take the help of the police, because ultimately whatever we are doing is doing in the best favor of the patient as well as the family as well as the society. So sometimes we do need to take the help of all these people, even the police, to bring these people in contact with the treatment and then start the treatment.
Yes, sometimes they ask, आप पेशेंट को बताए बिना कोई दवाई दे देंगे. What is your view about this? I know it is not supported, in academics and
Actually, COVID
evidence.
medication is as such, it is not been given, but many of these private, basically there is always, there is a pressure on the doctors also to give medication. So I will say disulfiram is one of those medications you should never write, because if the patient develops side effect, you are going to be, you will be in a trouble. But for the other medication like naltrexone, if you are being prescribing or you are prescribing bupropion to the person, I think these are the medications which can still be given. And even if the person is not willing and the family is requesting for the treatment, I might, sometimes, budge into the pressure of the family members and do prescribe them. So these medications are not that having a side effects, but disulfiram does. So only
Never
disulfiram
give disulfiram because it has very acute side
side
effects,
effects.
and it is because of this only that aversion develops. Because of the accumulation of the toxic metabolites in the body, nausea, vomiting, diarrhea, all these are there. So, and if you are not in a position to take care of this dehydration, it can turn out to be very serious. So
Yes.
never indulge in outside of hospital premises. It should be done in inpatient settings only. Any other your experience about substance use? Because you run the substance use clinic also in this. How long does that?
One of those problems that I have faced in my addiction, and it is not a problem across Delhi. It is a problem across whole globe. Once the patient is being out of the treatment, say for example he's no more taking the treatment from hospital, automatically they are lost, and again they will go back to the same society where the person was taking. So it is important that we have to have these alcoholic anonymous connections with the alcoholic anonymous group, narcotic anonymous. If the person can be made a participant in those meetings, automatically the outcome of the person is likely to be better. So besides this pharmacotherapy, besides this your counseling, please do involve alcoholic anonymous people, narcotic anonymous people, or Al-Anon group or Alateen group, so that the continuous treatment can occur. Even I have also tried the peer-to-peer, review. So one patient is being, attached to the other patient, and they will monitor the progress of each other patient. So whenever they are going to relapse, they will bring that person for the treatment. So this is one of those model on which I was working, and I have seen some success in the total number of days the person is remaining abstinent in comparison with the person who was being immediately just discharged from the hospital and allowed to remain alone.
There is one question about what approach can we have for a person on multiple drug abuse and alcohol. Is there a questionnaire for such cases?
Uh, say for example, whenever the person is taking the multiple drug use, ultimately we have to decide which medication is likely to cause more severe physical side effects. So that drug will be the primary drug for us. So say for example, he's taking tobacco, he's taking opioid, he's taking cannabis, then automatically we know that the opioid is going to create a difficulty. So for that we will be focusing our treatment of opioid in comparison to cannabis. Now, similarly, there are certain tools are available for the assessment of the person. For one is actually, as I have told you, one is a screening kit is available. So we have a UDS where there are 12 substances can be identified. So we can able to identify which substance the person was taking, and many people, those who are taking the substances, they will not give the proper information to us. So we go for this UDS kit, and based on that, we will be able to identify out of those 12 substances which substances the person are taking, and based on our understanding about the severity of the physical withdrawal, we will focus and target accordingly. And sometimes we do use polypharmacy. Say for example, the person is having an opioid as well as benzodiazepine use, then the treatment of the both is equally important at the same point of time. So this is how we manage. And
There is another one scenario Dr. Ashish Gupta is asking. A person is not showing any signs of alcohol dependence, but is consuming large amount of alcohol, about 9 to 10 bottles in 4 days, episodically, and then abstain for 2 to 3 weeks. What approach is to be followed here?
now here is a person actually, whatever this case which has been discussed just now is a binge eating pattern. So binge eating pattern is whenever the person is having a psychological impulse. So whenever the person is having a psychological impulse, he will start taking the substance, and he will take the substance for 1, 2, 3, 4 days. Once the binge is quenched, he will stop, and then he remains abstinent for 3, 4 weeks, or maybe 1 month or 3 months, and then again whenever the binge is having. So it is a kind of a psychological binge. So when a binge is present, the treatment is baclofen. We use a different medication, we use SSRIs, so to control those binges. So this pattern is actually a binge pattern and needs a different treatment.
Okay, there is one question, very good question about use of metronidazole in alcoholic patients. Before prescribing tablet metronidazole, is it necessary to ask for alcohol habit?
Yes, of course. Actually, I will say definitely, because metronidazole and alcohol can cause the same type of disulfiram reaction. So metronidazole should be avoided in the people those who are alcohol dependent. The second thing is actually here I would also like to add, sometimes when we are sitting in an emergency and a road traffic accident patient comes, I have seen immediately IV fluid or dextrose has been started, and without realizing that this person might be a case of an alcohol dependence syndrome. So for all those such kind of emergency, make it sure that you presume that the person might be a case of alcohol, and give the thiamine before giving the dextrose. Otherwise, we are likely to precipitate a chronic encephalopathy in that person. So when a patient comes to us of unknown, whether he's taking any substance or not, giving a thiamine, presuming it to be a case of alcohol dependence syndrome, also can save or can at least prevent the further complication in the person.
So, have you seen patients who were on metronidazole and they had this disulfiram like reaction?
I have seen the certain people like metronidazole, and they have taken alcohol. They have presented with us disulfiram type of reactions. So few, because
It does happen.
it
Many
happens.
prescribers don't believe that,
It
but it
happens.
does happen.
It happens.
So always, when you are prescribing metronidazole, always ask about this and withhold. Ask the patient to withhold alcohol for at least 48 hours after.
The,
I think there is some network issue with Madam.
yes.
Network.
मैम की आवाज नहीं आ रही.
Okay, let me ask her.
My electricity, got out. So I hope you are able to hear me.
Yes, madam. Now we are able to hear you.
Okay. I had to take the third part of the session today. You will be here, Manoj. Pratibha, are you there? Just hold on for another 15 minutes.
Sure, madam.
Let me take my session. Although I'll try to be brief here, because I think it's already late. Yes, can you see my slides?
Yes, madam. It's now visible.
Okay, now briefly, I'm going to touch about the benefits, risk, and misuse of psychotropic agent. I'm not going to in detail about the benefits. Already we know about this. They help us in relieving the symptoms. They bring about stability, and then, but however, these drugs have adverse drug reactions. There may be interactions, drug interaction, or the overdose may be troublesome here. And sometimes some of these drugs have misuse potential, so diversion, dependency, all these are the problems. So here, this balance, to achieve this balance is hard. These are essential medicines, but I always say these, any medicines for that matter, leave aside these psychotropic agents, they are double-edged swords. They have effects, they have side effects too. So the same class can also cause troublesome symptoms, may cause withdrawal problems or misuse potential. So here, the most important thing that we are worried about when we are using these antidepressants or anxiety drugs: sedation, falls, confusion, cardiometabolic effects, sometimes QT issues with some of the antidepressant, sexual side effects, anticholinergic burden, toxicity, depression. So these are some of the prominent side effects which are seen commonly. And when we are using these benzodiazepines, tolerance, dependence, withdrawal syndromes, rebound symptoms, these are commonly observed. So how do we tackle this, while we are treating this patient? So the principle behind is that the benefit should outweigh the risk here. And of course, we should not switch patients from one abuse potential to dependence on some other medicine, just because we did not monitor these patients properly. So these are most common use is, these are high value drugs which help us in mood, anxiety, psychosis, mania, attention and arousal, ADHD. Many times we use prescription stimulants. Then very common problem is sleep distress, pain overlap. So we may be using these hypnotics, anxiolytics, some antidepressants, or gabapentinoids. Here are gabapentinoids are pregabalin, gabapentin like drugs which are increasingly being used. The practical rule here that we need to follow is write the target in plain language before prescribing. What do we want to achieve? For example, if you are treating a panic attack patient, so you say that you want to reduce panic attacks from daily to fewer than one per week, or within 6 weeks. If this is clear in your mind, then the selection of the uh, proper appropriate drug for that condition chances will be more that you do it well. But the side effects, as I said earlier, but these can go wrong. So the team, it is a teamwork, most of the time, that different people have their own role, and we need to work in a team to decide uh, how do we want to handle this so that there is no harm or potential. There are many side effects related to each of these categories of medicines here, but the most three questions that you should ask is, what could happen when I use this drug? You can always access this information about the key side effects and who are the more vulnerable patient. What could happen to whom. Keep this vulnerable patients in mind, and how will we notice this early. The key here when we are using psychotropic is that if you review early, then you can identify these ADRs early and manageable. When it comes to antidepressants, most of them present early and are manageable. So, but many a times patients do not adhere to these regimen, whatever you have prescribed, is because of these ADRs, because they interfere with their routine. So one of the common reason for discontinuation is ADR. So elicit this early in the course of treatment so that patients do not fall out. With antidepressant, there is another thing that you must keep in mind, that there is delay in seeing the full effect of the antidepressant. It takes at least 4 weeks to start showing the antidepressant effect on the patient. So many a times, people expect that they will get a benefit immediately, like something like paracetamol or any other drug, but here the response would be little delayed. So do not label this as non-responsive unless you have given a fair trial of 6 to 8 weeks with good adherence. Many times, this is adherence is patients do not admit that they are not taking properly. So you have to be really looking for it, and you should know how to elicit those responses from them. So antidepressants, so anticipate that there may be initially some GI headache, insomnia, sedation may happen in the first 1 to 2 weeks. uh, if there are specific side effects like sexual dysfunction, weight change, it may happen on with some of the drugs. So you can switch to other drugs or reduce dose. So discontinuation symptoms will appear if stopped abruptly. I think that is the rule. Both Pratibha and Manoj will agree with all these psychotropic drugs. They should not be stopped abruptly, because then it increases the relapse risk. So always it is done in tapering. And once you start these patients on antidepressants, these are usually given for 6 months after the remission of symptoms. So treatment is long. It shouldn't be that here the patient's symptoms improved and then you stop. It should be continued for 6 months after the symptoms have been controlled. So this should be explained very well to the patients. But then one more thing with antidepressant is, watch for activation or suicidality early in the treatment, and for mania patients, switch if bipolar disorder is possible. Sometimes patients with antidepressants, because they shift, there is a activation, and they may move towards the manic side. So observe these effects. And generally misuse potential is not there, but practical problem, as I said, is poor adherence or early self-stopping before benefit appears. So overdose risk may vary by class, but then the tricyclic antidepressants are much more dangerous than the newer ones, selective serotonin receptor inhibitors and serotonin noradrenaline receptor inhibitors. So there are, guidelines. How do you select these antidepressants? You can use the side effect profile also to your benefit. Some of the patients with depression may have problem with insomnia, or some may complain of sedative effect with an antidepressant. So you can use timing, you can time the dose accordingly. You choose an antidepressant which is more appropriate for insomnia, which has a sedative effect, so that it helps the insomnia. Instead of using two different medicines, one for sleep and one for depression, you can make a choice here, select an antidepressant, so that one takes care of both the problems. So for example, if the patient is also complaining of in addition to mood symptoms, pain is also there, perhaps then serotonin noradrenaline receptor inhibitors would be more appropriate. So like that, you have to look at this first, that the right diagnosis is right, this drug is right fit for the patient. You give an adequate trial, at least 6 to 8 weeks before you label that this drug is not having any effect. So in older adults, you can allow 6 weeks. After remission, continue for 6 months. So, and staged tapering is always recommended. Do not stop abruptly. Now, coming to antipsychotics, extrapyramidal symptoms is one of the major problem. I won't go into detail here because it is not categorized under common mental disorders, but that does not mean that schizophrenia or psychosis are less common or less important at a primary care setting. The only reason that they are not included in the primary care package is because diagnosis is very important, and the diagnosis evolves over a time, and selection of drugs is very important because they have side effects too. So this is one of the group of psychotropics where you will find large number of side effects. Most troublesome are these EPS. So from safety point of view, they have been kept out of common mental disorders, but they are very required for acute behavioral problems, agitation, if the patient presents to you. So these side effects, EPS, are more important, more common, troublesome with the older antipsychotics. The atypical antipsychotics, second generation, third generation, these are less. So, but then do not confuse this EPS symptoms with anxiety, agitation, catatonia, worsening psychosis, or a drug effect. So this requires a careful assessment. So that is why it is left to the um, uh, specialist, mental health specialists here. But the key here is that you must recognize this early, lower this harm, and protect these patients, and have these antipsychotic benefits. One of the common practice that we observe is anticholinergics are used for the management of these EPS symptoms. But once they are on anticholinergics, they remain on these anticholinergics. These anticholinergics for management of these EPS are required only for few weeks, 2 to 3 weeks initially, and then once the patient starts tolerating and you have explained to the patient, it can be safely tapered off. An attempt to tapering of these anticholinergic drugs should be made, but I have I've seen even it happens in my own hospital. Once they are on trihexyphenidyl, the Pacitane is the common brand name that is given. They remain on this. So avoid, reflex anticholinergic use for every EPS compliant. Not a, you start low and then build slowly. At lower dose, EPS may not happen. So, there are, the doses at which EPS appears, then only you are required to use this anticholinergic agent. Because the downside of this is, what is the harm of continuing anticholinergic is they can worsen cognition or constipation. Now, reflex sleep as a prescription cascade, these patients develop constipation and then we prescribe laxatives for this patient. So this is how the prescription cascade goes with antipsychotics. These are definitely high value medicines, but they need monitoring. They need monitoring for metabolic side effect, cardiometabolic risk, EPS, I have said, sedation, orthostasis, all these things should be, managed. Out of these, they don't have any misuse potential, but Q-tipin misuse has been reported, and often these are used for sedation or in patients with other substance use disorders. So I think I have made this, time to benefit, explain this to patients clearly. Antidepressants take days to week. Antipsychotics have an immediate effect, the hours to days for calming and days to weeks for full stabilization. Benzodiazepines, the effect may last for minutes to hours. Misuse potential with, I'll come to this. When it comes to misuse potential, the hotspot is benzodiazepine, prescription stimulants, opioids, and gabapentinoids. So how do you do this? Because these patients keep on increasing the dose. These benzodiazepines have rapid benefit, but they have narrow indications and highest dependence risk. So these should be given for the shortest course, 2 to 3 weeks, not more than that, in smallest quantity that matches the plan, and then taper rather than stop abruptly if use has become prolonged. So these patients will come to you, early refill requests. They will have, usually they have multiple prescribers, and dose creep are practically red flags. They go on increasing their doses on their own. So risk of dependence is particularly, on one hand, abuse potential is there. So you need to select these benzodiazepine according to their misuse risk. Short acting have a higher abuse potential. So rapid onset agents such as alprazolam and diazepam, that is why we don't give alprazolam, because it has a highest abuse potential. Select a lower abuse potential, intermediate or slower onset agents as oxazepam, clonazepam for this. And of course, elderly patients or patients who report with falls. Elderly patients come with cognitive impairment, so avoid long acting drugs in these patients. Falls and fractures, prefer short intermediate acting choices and dose carefully. So but you must, unfortunately, many patients who are diagnosed with heart attack, or they are usually given this alprazolam, and they continue taking this alprazolam ever after the MI. So please avoid doing this. Look at this. There is a dependence risk. So I can't go, because of the paucity of time. I'll not go into the detail of these benzodiazepines are selection on the basis of the duration of action, their metabolic pathways. Most of them, are metabolized by hepatic metabolism. So avoid these diazepam, alprazolam, midazolam in liver dysfunction. Go for lesser hepatic dependence drugs like lorazepam, oxazepam, temazepam. Remember this as a lot group for hepatic ARP. Then I think I can. You can also use non-benzodiazepine medicines for insomnia. There are several drugs with different onset of action, duration of action are available. And you can choose, sleep, whether they have problem in initiating sleep or continuing maintaining sleep, elder patients, or whether they have substance use history. So these are the patients who can be put on non-benzodiazepine. Again, there is a criteria for that. I'll not go into this. So always clarify the target. What do you want? What symptoms or function or risk that you are actually trying to change? If you do this every time in the same sequence, why are you starting? Why are you continuing? Or why are you switching from one psychotropic to another? And de-prescribing is equally important. I think Pratibha and Manoj both were emphasized on this. If there is no benefit or risk is dominating, reduce thoughtfully and keep treating the underlying condition. So taper or stop is also a decision. It should not happen that the patient is, continue same treatment, and he just unnecessarily gets those medicines. So continue is not a decision. It is just a passive thing that happens. And unfortunately, many prescription, if you study, you'll find that it is written like that only. So any patient who has psychosis, mania, severe self-neglect, high suicide risk, overdose, delirium, severe withdrawal, these patients should be referred to higher center immediately. I think there is not much time. I'll skip the prescription stimulants here. Opioids, of course, we are concerned. Same rules apply, that you need to carefully weigh benefit and risk, and aim for relief that improves mobility, sleep, breathing, or nursing care, not pain scare chasing alone. Pain score, if you just chase that, perhaps the dose will escalate more than required. So there are side effects with these. You should clearly have the clear goals. How do you want to administer this pain care? This should be individualized, monitored, and it should be safe. So go for safer, as Manoj was saying, naloxone, offer naloxone when overdose risk is increased. So risk, always it saves time and helps the patient. I think I'll switch over, but the good team-based practice, would look like where the prescriber responsibility and nursing responsibilities are paired, and you look at a patient from both the sides. You do carefully prescribe, but then you also monitor, the nursing team or yourself can monitor patients for proactively look for these side effects and reinforce education and escalate concerns early. Patients, sometimes you have to prescribe according to the patient's preferences also. So you should, I think monitoring requires you monitor the baseline before and at initiation, then decide on the follow-up after starting or changing the drug. Actively look for these. So कुछ साइड इफेक्ट्स तो नहीं है, ऐसा पूछने से कई बार we don't get the right answers. So maybe you can ask the patient, how is this medicine affecting you? Often this would work better than only asking about any side effects. Anyway, follow guidelines. Guidelines are available. Mental health guidelines, substance use disorder screening and management guidelines are available from Government of India. WHO guidelines are also there. You can also refer to this our standard treatment guideline. This is a ready reckoner. It is not as detailed as the mental health guidelines are there, but it does give you, how do you start, how do you step up, how do you step down, when do you refer, all those things are covered here. So, but the bottom line here is that, do follow guidelines. If you are not following guidelines, you should have justification for not following, because in court of frequently many of these cases, especially the schizophrenia, many patients, they also land up in courts. So again, then the burden of proof that the standard of care was followed lies on the treating prescribers. So the key takeaway I think I would like to end is benefit is real. So don't shy away, don't refrain from using these. They have good effects. They improve function when there is a clear indication, and if you have a clear review plan. I've seen, many times these drugs are available at the health facility, but people are not using. So you should use it. Benefit is real, but risk is dynamic. So, what do I mean by this? The balance can change with age, comorbidity, co-prescribing, dose escalation. So keep on reviewing. Misuse is accessible. You can ask these questions directly, by which route, quantity, whether they are sharing, whether they are getting early refills, or their polysubstance use is there. Monitoring is treatment here. Good follow-up is not admin work. Many of us think that it is administrative. It is, however, safe prescribing actually, and de-prescribing should be part of the care. So documentation and legal aspects are very important. Very often we state that we have no time in high pressure setting where patient load is high. We very frequently give this excuse. This is in the eyes of law, and many of these patients may land up over there over time. You don't know. So documentation, even if you leave out the legal implications, it is for the patient's good. If the documentation is there, the plan, you can treat the patient effectively and refer these patients timely to higher level. And especially risk assessment documentation is very important. Patients' consents and psychoeducation provided, and of course must understand basic legal responsibilities under Mental Health Care Act 2017 or national guidelines. So that is the minimum required. I think I'll stop here. Manoj and myself, we have written one article for mental health problems for primary health care. It is under publication. Soon we will be getting it. So we made these flow charts. When the patients come with general problems, how do you go about assessing? The stepwise flow chart is given. Similarly, if you have patient who is agitated or you are suspecting psychosis, how do you go about it in a stepwise manner? It is given there. We will share this once this is published. I think I'll stop here. If you have any questions, we would be happy to answer. Sorry, today the session has gone quite long, but I think the scope of the sessions was also very broad today, and to cover this in just 2 hours is was difficult, but I think I must thank my experts here today that they have done this beautifully and covered the major basic aspects here. There is, Manoj, there is one question: how to locate government de-addiction centers? Is there any directory?
Like say for example, am I audible?
Yes, yes.
Say for example in the Delhi there is one directory is present. So we have 69 centers which are registered, because all de-addiction center has to be registered with the state mental health authority. So if you will just enter into state mental health authority, say for example state mental health authority Tamil Nadu, so you will get the registration of all those de-addiction center as well as those nursing homes which are providing the psychiatric treatment. It is mandatory that a mental health establishment has to register with the state mental health authority as well as the de-addiction center. So just enter into your state level mental health authority, you will get that answer.
Okay. So you know where to look for this information. There is a question about how effective is multi-behavioral therapy in addiction.
Like actually the goal of the treatment is basically we wanted to that multimodal treatment is the option. There is no eclectic approach. Multimodal therapy or eclectic approach is the option. If we just plan for one form of therapy, it may not work in a patient's addiction. So we have to plan for psychological, we have to plan for psychosocial aspects. So multimodal treatment is the treatment of choice, I would say.
Okay. I think some of you, these are all, there were one or two questions I hope, is Pratibha there?
No, ma'am.
Okay, Manoj, maybe
answer.
you can.
I can answer.
Maybe just look at what was the question. Okay, Ranjit, could you, this is up here in the chat box. Could you? How to treat dissociative disorder and somatoform disorder?
Say for example, if you are come across a dissociative disorder, basically a dissociative disorder is arising because of the underlying anxiety. Because of the anxiety, the person has been dissociated into two identities. So if you want to bring that, reduce the stress level, automatically dissociation will end. So the best treatment which we can give to the person of dissociation is give it a tablet of lorazepam or give an injection of lorazepam, and within a period of 5 minutes or 10 minutes, you will see that there is a remarkable improvement will occur in the patient. So if you can able to give an injection lorazepam to the patient, prefer to give by IM rather than IV, because I will not prefer that the people should be given IV, rather you should give IM, and within a period of 10-15 minutes you will see the dissociation will improve substantially. Now every dissociation is because of the stressor, we believe, so then automatically there is a need to ask for what is the underlying cause which is manifesting in the form of a physical symptoms of dissociation. So if we are able to identify the cause, we treat the psychological through the psychological means. Somebody might be having issues related to, marriage, money, interpersonal issues. So we have to find out the stressor. And if, say, for example, still we are not able to find out, giving a low dose of antidepressant of SSRIs can benefit these patients.
How do you, there is a question about how do we decide on the endpoint of pharmacological treatment of anxiety, and for that matter, depression and...
Similarly, actually, there is no, standard answer of this particular question, because actually, whenever we decide about any treatment, there are multiple factors which might be contributing. There may be, underlying trait anxiety in the person. There may be family history. There may be ongoing psychosocial stressor. So it is very difficult to say for how long you have to treat. So, say for example, if you have treated the patient for a 6 to 9 month period, you can talk to the patient and take a call that it is basically a mutual agreement that I'm not going to reduce your medication. If you show the signs of relapse, we might increase it, and if you are showing the consistently improvement and there is no withdrawal symptoms, we will ultimately taper and stop the medication. So there is no uniform answer of this particular question. It ultimately depends on various factors, and ultimately it is a collaborative decision which is being taken with the patient.
Unlike depression, where you continue 6 months at least
Yeah.
beyond
Yes, ma'am.
remission, but anxiety, this is no set, but it is with the patient that you have to assess and decide, whether they would like to. Okay.
Yes.
There is a question about abandoned mental health patients who have no caretakers. When a primary and secondary center do legally and technically what they are supposed to do.
Sorry, I didn't miss your question, ma'am. Sorry.
This is about abandoned mental health patients who have no caretaker. What a primary level or secondary center do technically and legally, which is legally correct also.
Means, say, for example, if any person who is suffering with psychiatric disorder is abandoned, then it is a state responsibility. State is the guardian of that person. So we have to call the police. The police will take that person into custody and get this person treated to the nearby mental health establishment. So in these conditions, we should not be, there should be somebody. As a doctor, I will not get involved in treatment of a person who is abandoned. Let there be a nominated representative in the form of a caregiver, in the form of a neighbor, friend, or anybody. And if nobody is available, it is a state responsibility. The police should be there. Then only I will treat. Because giving any medication to the patient without his or her consent, usually which is not found in the people those who are abandoned, then ultimately it is only after the court order or the police intervention I will decide.
But do seek police help here, assistance here.
Yes.
They can certainly help you, and with court orders, these patients can be
Treated. Yes, ma'am.
Many mental health patients won't or can't reach facilities due to being uncontrolled or aggressive state. There is no dedicated transport system for mental health patients. What is the next best step here?
Generally, actually, this may be partially true, or this is because if you talk about the Delhi has a only model which is not available in the rest of the part of our country, mobile mental health unit. So whenever there is an aggressive and a violent patient, they call us just like the police 112 or 100, and the our mobile mental health is ready to help those people, those who are aggressive and violent. Now this kind of model is need to be applied in the rest of the country, but till the time it is not happening, then we can call ambulances, that like CATS ambulance. They will only go and bring those people with the help of the police, because aggressive and violent patient ultimately.
Yeah, aggressive patient, even cat, these ambulance people may refuse.
So it is that is why the police is required. For the police will help in escorting this person to the nearby mental health establishment.
There is one question about how do we differentiate somatoform autonomic dysfunction from depressive and panic disorders when they are accompanied with somatic symptoms, also since they may also initially manifest with primary somatic symptoms.
I think maybe this question is out of the scope of this. There's like definitely, I will say actually no, there can be so many differential diagnoses unless or until we have not assessed it properly. It is very difficult to
Assessment is careful assessment and temporal timelines. When did what happened? Careful history will help you decide. And the response to you may rule out acute causes or common causes, somatic causes first. So that you should not miss anything in these patients. And of course, if you don't find anything, you are not able to pinpoint diagnosis, perhaps then you can think in those terms of depression or so careful history taking is very, very important. I think last question is about methadone versus buprenorphine in heroin detoxification. What are your comments?
Actually, I will go for methadone. Methadone has a longer duration of action, so methadone will definitely take an advantage over buprenorphine. But unfortunately, we don't have methadone that frequently available in whole of the country. So buprenorphine will be chosen only because methadone is not available. But I will go for methadone.
But one precaution with buprenorphine is, this is again initially only for few weeks that you are trying to bring down the how do you say opioid dependence. You put the patient on because this is a partial agonist, so symptoms of withdrawal will be less, but it should not be continued for a long time. uh, 8 to 12 weeks is the time that you give, and then you start tapering buprenorphine. Otherwise, the case would be you take care of the heroin dependence, and then you develop the dependence on buprenorphine. What is
Madam,
your
that is very definitely you are correct that on one hand we have stopped the heroin dependence and the person has become dependent on buprenorphine, but the globally buprenorphine is still advised to the people those who wanted to continue and they don't wanted to give up completely. So buprenorphine
yeah?
maintenance may be used for years together. Madam. So
Okay. So, but the guidelines don't say that. Why don't the guidelines are
actually, whenever the
revised?
guidelines are made, there are always a people who are having a moralistic values. And they always wanted to a society which is completely teetotaler. So they will definitely say after 3 months you stop it and then give the naltrexone and then step naltrexone after 6 months. But what we have seen the people of the opioid user, they continue.
Practically, it is difficult
Yeah.
in the
So
clinical setting. It is difficult to withdraw. So, but attempt should be
it should
made
be made.
if you
Actually,
can.
it should be made.
Always, yeah, because patient will always find it difficult to taper on their own.
Yes, ma'am.
But with persuasion, counseling, perhaps they can be
They can reduce and
persuaded to taper this over a period. But that depends on the circumstances also, the situation. What are the stressors or the precipitating triggers here. So do take care of it. I think we had a very, very long test session today, but I think the questions were very pertinent. Thank you, both my experts, Pratibha and Manoj, for coming and sharing your experiences here and covering this exhaustive topic in a time-bound manner. And thank you to all of you, the participants here. Your questions make these sessions lively and keep us also motivated. So see you next time. Next session is on May 16th, and we would be covering the myocardial, how do you handle at the first point of contact myocardial infarction, and how do you handle trauma, bleeding as first aid uh, in first hour management at peripheral facilities. Uh, until then, goodbye. We'll see you. I hope you have all completed pre and post test. Feedback, please do also provide feedback. You can also write your comments, topics of your interest that you would like us to take, because then when we are planning the series topics, we can take cognizance of that. With that, I think we'll close this session. Ranjit, can we close this session?
Yes, ma'am.
Thank you, Manoj. Bye bye.
Thank you. Thank you all.
हाँ बोलो।
राधिका कह रही है कि मैं रोटी बना दूं